Dr. Singh, I can see you now. Dr. Shinoy, good evening.
Yes, good evening. I'm here.
Yes, sir, I can see you. Thank you so much for joining us today.
Thank you.
Hello, Professor Paulo. How are you?
I'm fine, and you?
Hi, sir. I'm good. Long time.
Happy to see you again,
Yes,
and
sir.
to see Virendra and all the other Indian friends I have.
Yes.
I hope to see you in presence as soon as possible.
Yes, hopefully. Hello, Ajay, sir. Good evening.
Good evening, Dr. Aki. Good evening, Professor Paulo, sir. How are you?
I'm fine, and you?
I'm good.
Good evening.
Hi, Dr. Ashish. How are you?
I'm good, sir.
Hello, Ashish, sir.
Hi. Hi.
So we still have another 9 minutes.
Yeah.
So, sir, Ashish, sir, can I ask? Ajay, sir, what do we...
हाँ,
हम लोग का रोल बता दीजिए, सर, हमें क्या कर... Sir, कि...
We'll ask you the questions, Rakhi.
Okay, sir. Hi, sir.
Get ready.
Hello. Good evening. Good evening, sir.
so Dr. Rakhi, you will be appearing for the exam with Dr. Virender Singh as an external
Okay,
exam.
okay. Very tough.
And Ajay is the invigilator.
Good evening, sir. How are you?
Fine. Good evening, Dr. Paulo. It looks like you reduced some weight.
Sorry?
You reduced some weight.
Yeah, it may be.
He's working very hard.
Yeah.
Where
Very
is-
I'm currently in Frankfurt, in Germany,
Oh.
Germany.
because we have a meeting yesterday, and the day
Oh.
before I was in Brussels for another meeting. So I'm in the room of the hotel now.
Oh,
Okay.
you're looking tired, sir.
Maybe, I want to go home. I had a flight this evening.
Okay, okay.
Okay. Ajay,
Yes, sir.
I'll just introduce Dr. Paulo at the start, and then
Okay.
after that, you introduce the other panelists.
Right, sir. Right. Sir. Has Dr. Khanduri joined?
Yeah,
Dr.
yeah, I am Dr. Kanduri. Yeah, Dr. Jain, I did talk to you.
Yeah,
here.
yes.
I am listening to stalwarts. My role is to appreciate how well Dr. Paolo will tell us what's new, and I'll appreciate Dr. Raki, who is thick and thin into this, and she will be enlightening us. So I am one of the peripheral
No,
workers
Dr. Khandu.
who will sort of take the research to the people. So you are the people who will be telling us what's
No,
new.
no, after the Dr. Professor Paolo's talk, Dr. Virender Singh is going to ask you some tough questions.
No, doctor, he is himself a stalwart. So, I am so much impressed by his research. And he is the one who is actually bearing the torch for midodrine. And in periphery, we are all started using it because
Yes.
of his good research. And it's made, I think all the guidelines also are now talking about midodrine. So this is one of the credit to Dr. Paolo and Dr. Singh.
Yes. I believe Dr. Malik, Professor Malik from Pakistan, has he joined? Professor Malik?
I think somebody is joining now.
He has
Professor-
joined.
He has joined?
Yeah, he's just there.
Yes, yeah, he just joined.
Okay, Professor Shinai has joined. Professor Akash Shukla.
Okay, he's not there. He's not there.
Who's not there.
Good evening, everyone. I'm Dr. Kashif Malik from Pakistan.
Good evening, sir. How are you?
I'm fine.
You are all set for it.
We'll just wait for 1 or 2 minutes. Dr. Anil Arora is about to join.
He'll introduce the things. Yeah.
Yeah.
Dr. Arora is just joining in, please.
Hi, Anil.
Hello, good evening and good
Good
day
evening.
to everybody.
Hi, Akash.
Good evening, sir. How are you?
sir.
Nice to see you all. If you're all ready, should we start the program, Ashish?
Yeah. I think we should start. You have to give the introductory remarks.
So we are live and ready to go.
Good morning, good afternoon, and good evening to all of you, of all the participant faculties, moderators, and the chairpersons for having joined on this session. It is our constant endeavor on the part of Institute of Gastroenterology, Hepato, Biliary, and Pancreatic Sciences from Sir Gangaram Hospital to fish out the best what has been published in the recent literature in the field of gastroenterology and hepatology. So to bring the jewels out of the ocean of knowledge, we are lucky to have a galaxy of stars from all across the globe who are going to enlighten us about the recent advances in the field of gastroenterology and hepatology. Today, we have excellent topics on advances in liver diseases, something which is so relevant on day-to-day basis in patients who are practicing gastroenterology and hepatology as their field. So in lieu of the recent advances, what we have selected is we have had 5 topics today. We have management of refractory ascites, non-alcoholic steatohepatitis, management of alcoholic hepatitis, hepatitis B, and hepatocellular carcinoma. So what we have planned today is that we have the best of the speakers available in the world who are going to deliberate with us the nuances of management of the various topics which I have already mentioned, in addition to their clinical application based on the recent advances in the last few years. With that, I'll hand it over to Ashish to carry forward the proceedings.
Yeah, thank you, Dr. Arora, for those introductory remarks. So we'll go on to the first session. The first session is recent advances in management of refractory. And I would like to invite the moderators of this session, Dr. Virender Singh, who's from Chandigarh, and Dr. Ajay Kumar Jain, who's from Indore, to take over the proceedings from here. Dr.
Thank
Virender.
you. Thank you, Dr. Anil. Thank you, Dr. Ashish. So, the first session on the refractory ascites, we have none other than Dr. Paolo Angeli. You could not have got any speaker better than Paolo. And I don't have to tell about Paolo Angeli. He has been working for so long in this field of ascites, HRS, ACLF, and infections. And he is now the editor of Journal of Hepatology. He remains quite busy. And let us listen from him the management, especially the recent advances in the management of refractory ascites. Our panelists, Dr. Jain will introduce you, the different panelists, before I invite Dr. Paolo for the presentation.
Thank you, Professor Virender Singh. Thank you, Dr. Arora and Dr. Ashish Kumar for giving us this opportunity. I have a privilege of inviting some of the eminent people who are working in this field, along with Professor Paolo, to enlighten us on refractory ascites. The panelist for this session is Professor Kashif Malik, who is the head of the Department of Gastroenterology and Hepatology from Sheikh Khalid bin Zayed Medical College, Dental College, Lahore. Professor Rakhi Maiwal, she is currently working as additional professor of hepatology, and she is head of the liver intensive care unit at Institute of Liver and Biliary Sciences. Professor Katie Shinoy, he is head of the Department of Gastroenterology and Hepatology at Sri Gokulam Medical College and Research Foundation, Trivandrum. Dr. Arun Khanduri, who is a prominent practicing gastroenterologist at Kanpur, and Professor Akash Shukla, professor and head Department of Gastroenterology, St. GS Medical College and KM Hospital, Mumbai. So without wasting much of the time, I invite all the panelists to join, and we will have a panel discussion on refractory ascites once Professor Paolo Angel gives his talk. And then we will take the questions from the chat box. I request all the participants to put their question in chat box, and we'll take one by one, and we'll put to the panelists as well as to the Professor Paolo. Over to you, Professor Paolo.
Thank you very much. Dear chairmen, first of all, I want to thank Dr. Anil Arora for this kind invitation. This gives me the possibility to see again so many friends I have in your big country. And I wish to meet each of you as soon as possible in person. Well, going to the topic, after my disclosure, I will speak briefly about definition, prevalence, and prognostic impact of refractory ascites in patients with cirrhosis. You all know the definition. Refractory ascites is an ascites that cannot be mobilized or the early recurrence of which after paracentesis cannot be prevented by standard medical treatment, that is moderate sodium restriction and diuretics. You all know also there are two subtypes of refractory ascites. The resistant ascites, that is defined as ascites that cannot be mobilized or the early recurrence of which after paracentesis cannot be prevented because of lack of response to dietary sodium restriction and intensive diuretic treatment, and intractable ascites, that is defined as ascites that cannot be mobilized or the early recurrence of which after paracentesis cannot be prevented because of the development of diuretic-induced adverse effect. And you well know that intractable ascites is much more common than resistant ascites. And you know that the most common diuretic induced adverse effects are renal failure, hepatic encephalopathy, hyponatremia, muscle cramps, and derangements of potassium homeostasis. The probability to develop refractory ascites for a patient who developed the first episode of ascites is 70% at 5 years. And the development of refractory ascites is associated with a poor outcome. You can see that the probability to survive is less than 50% at 2 years. Let me go now to the pathophysiology of ascites and refractory ascites, because we changed completely our mind on this during the last 10 years. In fact, for more than 20 years, we went on thinking that the only driver of decompensation and further decompensation in cirrhotic patients was a progressive increase in portal hypertension, a related progressive derangement of the cardiovascular function, and a related progressive increase of the degree of activation of vasoconstrictor and sodium retaining factor. This is only partially true, because if we look to the most advanced phases of the liver disease, there is not a further progressive increase in the degree of activation of vasoconstrictor and sodium retaining factor. Then, during the last 10 years, we learned that a new syndrome may develop at any stage of the chronic liver disease, but particularly in decompensated cirrhosis. And this new syndrome is called acute on chronic liver failure, and is characterized, first of all, by an acute decompensation of the liver disease. What it is the sudden onset of one or more than one complication of liver disease, ascites, gastrointestinal bleeding, bacterial infection, hepatic encephalopathy requiring hospitalization. Then, patients should develop organ failure, and finally should have a very high mortality rate at 28 days, higher than 50%. Now, a patient may develop acute decompensation and acute on chronic liver failure, even in presence of normal degree of activation of vasoconstrictor and sodium retaining factor, but never in absence of systemic inflammation. So systemic inflammation may be a second powerful driver of decompensation. Systemic inflammation is not only present in patients who develop ACLF, acute decompensation. Systemic inflammation is a very early event in the course of the liver disease, still present in patients with grade 1 ascites. I mean ascites that can be detected only by ultrasonography, and worsens thereafter in patients with grade 2 and 3 ascites, and overall in those with difficult to treat ascites, so patients with recurrent ascites and refractory ascites. Let me speak about a third potential driver of decompensation, oxidative stress. This is the molecule of albumin. In position 34, there is a residue of cysteine that is capable to bind ROS. In doing so, albumin is oxidized, either in a reversible form, human non-mercaptoalbumin 1, or non-reversible form, human non-mercaptoalbumin 2. And the sum of oxidized albumin is progressively increasing along the course of the liver disease. So a third potential driver of decompensation may be oxidative stress. So the problem is how to put together the progressive increase in portal pressure, systemic inflammation, and oxidative stress. of course, in a new theory. And nowadays, we think that the main consequence of portal hypertension and liver failure is bacteria translocation, which is the cause of systemic inflammation and oxidative stress, and the only cause of the cardiovascular dysfunction, and so of the reduction of the effective circulating volume. There is no other mechanism by which portal hypertension and liver failure can induce the macrovascular dysfunction and the effect hypovolemia. Then systemic inflammation, oxidative stress, together with the activation of vasoconstrictor and sodium retaining factor are the cause of ascites. But let me say that systemic inflammation and oxidative stress generate a vicious cycle by which there is a progressive further increase in portal pressure, a progressive further derangement in liver function, a progressive increase in the rate and severity of bacteria translocation. So at the end, there is a progressive increase in the degree of systemic inflammation and oxidative stress. So at any stage, at any time of the liver disease, organ failure may develop spontaneously or as a consequence of the intervention of a precipitating factor at the hepatic level or at extrahepatic level. Let me go now on the clinical ground, speaking about prevention of refractory ascites. Is it possible to prevent refractory ascites? The answer is yes. How? For example, giving beta blockers. But we have a problem with beta blockers. Very few centers around the world measure HVPG before and after giving few pills of propranolol. So in most of the center, when we give a pill of propranolol, we look like to play a blind and fly game looking for responder and non-responder. This is not good in an era of personalized and precision medicine. What we have else to prevent refractory ascites? We have the long-term use of albumin. This is the ANSWER study we performed some years ago in Italy, a randomized controlled clinical trial, including more than 400 patients with responsive ascites that were randomized one by one to the standard medical treatment or to the standard medical treatment plus the long-term use of albumin, 40 grams per week. And you know, the long-term use of albumin was capable to prevent the development of refractory ascites, was capable to prevent the development of SBP, of infection other than SBP, of hepatic encephalopathy and renal failure. And overall, the long-term use of albumin was capable to improve survival in these patients. Well, let me go now to the management of refractory ascites. The first therapeutical option is therapeutic paracentesis. And in this clinical setting, refractory ascites, therapeutic paracentesis should be followed by plasma volume expansion with albumin independently from the volume of ascitic fluid removed. But when therapeutic paracentesis become too frequent, more than 3, more than 4 in a month, what we can propose to our patient? We can propose, first of all, TIPS. And we all know that TIPS is much better than paracentesis in the control of ascites. We all know that the use of TIPS is associated with the risk of hepatic encephalopathy, severe hepatic encephalopathy. And we all know that the use of TIPS is not associated with a clear-cut advantage in terms of survival. In addition, if we look to our patient with refractory ascites, and we look at the contraindication to the use of TIPS, it is easy to realize that we cannot propose TIPS in more than 50% of patients with refractory. How to move away from this stagnant area? There are two possible ways. The first one is to anticipate the time of TIPS, moving away from refractory ascites that probably is a too late indication and moving towards recurrent ascites. I state this on the basis of only one controlled clinical trial in which small diameter covered tips was used for the treatment of recurrent ascites that was defined by less than 6 large volume paracentesis during the last 3 months. Again, tips was much better than paracentesis in the control of ascites. The use of tips was not associated with the risk of hepatic encephalopathy and was associated with an improvement of survival. We accepted the message coming out from this trial in the EASL guidelines. We stated that in patients with recurrent ascites, the use of small diameter covered tips may improve survival. But you know, there are still a lot of contraindications to the use of tips. So the second way to try to move on this problem is to try to select better our patients that we candidate to tips. And recently we published in the Journal of Hepatology a new index of post-tips post-tip survival. That is the Freiburg Index of post-tip survival. It includes bilirubin, creatinine, age, and others. It makes possible to divide your patient who are candidate to tips into 2 cohorts, low risk group and high risk group. And if your patient falls in the high risk group, please forget the tips. Otherwise, his or her survival will be less than 50% at 1 year. Well, what we can propose else in patients with refractory ascites who are not candidate to tips? One option is alpha pump, a system that makes it possible for the patient to urinate his own or her own ascites. What we have? A controlled clinical trial proving that alpha pump is much better in the control of ascites, proving that alpha pump has not any positive impact of survival as compared to therapeutic paracentesis, proving that alpha pump can improve quality of life, but there are still some concern about its use in clinical practice related to the adverse effect, particularly AKI, and to persistent technical problem who may require the replacement of some component of the system or even the system explant. What we can propose else? Vasoconstrictor, clonidine. It seemed to improve in some way the response to diuretics, to reduce the rate of adverse effect induced by diuretic, but nobody around the world is using clonidine in the treatment of patients with responsive or refractory ascites. What we can propose else? Midodrine. There is some evidence from Virendra group proving that midodrine may improve the control of ascites. But you know, another possibility is to use together midodrine plus an aquaretic, tolvaptan, because they seem to act synergically in patients with refractory ascites, in spite of the fact that tolvaptan per se does not have any effect. When we wrote the guidelines, we thought that there was not enough evidence to suggest the use of midodrine and other vasoconstrictors as alpha pump in clinical practice. What was published thereafter the publication of the EASL guideline? Well, an analysis of all the trials using midodrine or clonidine And there is some positive result in terms of less change in plasma renin activity after therapeutic paracentesis in patients with refractory or recurrent ascites. There is some evidence that there is a less increase in serum creatinine after therapeutic paracentesis in patients with refractory or recurrent ascites. But then there is also a controlled clinical trial using midodrine plus albumin, showing that even if midodrine and albumin are capable to modulate, to reduce the degree of activation of plasma renin activity and plasma aldosterone, there is no effect on the clinical ground, no reduction of the rate of complication, no improvement of survival. So we do not change our mind. We think that we need further study on vasoconstrictor and of alpha pump before to suggest their use in clinical practice in patients with refractory ascites. What we use in our unit in patients with refractory ascites, the long-term use of albumin. On the basis of this real-world trial, this is not a controlled clinical trial, in which we enrolled 70 patients with true refractory ascites, and we assigned this patient to the standard of care or to the standard of care plus long-term albumin infusion. And, you know, the long-term albumin infusion was capable to reduce the mortality rate, was capable to reduce the rate of emergency readmission to the hospital, so the quality of life, for any type of complication of the liver disease, with only one exception, variceal bleeding. Now we think that when we give albumin for a long term, albumin is exerting not only through the oncotic property of the molecule, but mainly through the non-oncotic properties of the molecule. There are several, but I want to focus on the anti-inflammatory action of albumin. Albumin is capable to go into the immunocell, the green point you see in this line, particularly when there is a pro-inflammatory state. Within the immunocell, albumin is capable to reduce the production and the release of pro-inflammatory cytokine. You can say, oh, this guy is speaking about cell. Let me move to an experimental model of decompensated cirrhosis. In the cardiac tissue, on an experimental model of decompensated cirrhosis, albumin is capable to normalize the expression of TNF-alpha protein. By this, it is capable to normalize the expression of inducible nitric oxide synthesis protein, so to reduce the release of nitric oxide, and so to avoid all the negative impact that nitric oxide has on the beta-1 signaling receptor in the cardiomyocyte, and so on cardiac contractility. For this, albumin is capable to recover the cardiac contractility in this experimental model of decompensated cirrhosis. This is not possible with any other plasma expander. You can say, oh, this is an experimental model of decompensated cirrhosis. What about patient? Now we have some evidence that albumin is capable to improve the cardiac function even in cirrhotic patients with acute decompensation. The problem is we should give a large dose of albumin, 1.5 grams per kilo body weight every week, to be sure that we can obtain a significant and stable anti-inflammatory action. Practically, this means that we should normalize the serum albumin concentration in our patient. So let me summarize what I said. Beta blockers and long-term treatment with albumin are capable to prevent decompensation and also refractory ascites in patients with cirrhosis. Long-term use of albumin is capable to improve survival in patients with responsive and refractory ascites. Tips should be considered in patients with the recurrent ascites, refractory ascites, and patients in whom paracentesis is ineffective. In patients with recurrent ascites, the use of small covered tip can improve also survival. Tips, the rule of other procedure that should be proposed for patients who are now candidate to tips, alpha pump, vasoconstrictor, aquaretic, should be tested in further investigations. Thank you very much for your attention.
Thank you, Dr. Paulo, for a wonderful lecture. And now we'll have the questions from the audience as well as the panelists. Any question from the panelists to Dr. Paulo?
Professor Virender Singh, can I put few questions to Professor Paulo, which are in the chat box?
Yeah, go ahead. Go ahead.
So, Professor Paulo, the first question is by Dr. Ashwini Singhal from USA, and he is asking your comment on your experience and your guidance on the routine use of IV albumin use on a long-term basis in liver-related morbidity and mortality. So he wants to know what is the ultimate outcome or survival benefit in patients who had cirrhosis with hypoalbuminemia.
As I stated, the evidence that we have up to now, and now it appears as a guidelines in the Italian guidelines for the management of patients with decompensated cirrhosis, is that the use for a long term of 40 grams of albumin every week is capable to improve the control of ascites, is capable to prevent several other complications in patients with decompensated cirrhosis, and overall to improve survival. So the indication now is present patients with responsive ascites who are treated with dietary sodium restriction and diuretics. These are the patients who will benefit for the long-term administration of albumin. And the target should be to give albumin at the right dose for a long period of time. It makes no sense to give albumin for 1 week, 2 weeks, 3 weeks, and stop. This makes no sense at all. There is no impact on clinical ground. And the dose of albumin should be enough to almost normalize the serum albumin concentration, so that to put the serum albumin concentration in your patient from 3.5 to 4 gram TL.
Okay. Paulo, if there is already a serum albumin of 3.5, and in that, do we need to give the serum albumin, or we just wait?
Thank you for this question. You know, there is with albumin, we have two problems. Hypoalbuminemia, but also dysfunctional albumin. The right target in the future will be not normalize the serum concentration of total albumin, but the serum concentration of native, fully active albumin. Up to now, we have not a lab investigation that can be applied bedside to evaluate the presence of native albumin, but this should be our target in the future. So even a patient with the apparently normal albuminemia may have a defect of native and so biological active albumin.
Dr. Paolo, I'm Dr. Khanduri from the panel. I just wanted to ask that one of the factor like bacterial translocation, we have some antibiotics and at least some gut decontaminants like rifaximin. So as a peripheral gastroenterologist where albumin is very costly, there were 1 or 2 trials showing rifaximin in long-term effect on pathophysiology. So what is your take on that? And are there further trials going on in that direction?
Thank you very much for your question, a big question. So I fully agree that the evidence of albumin is a proof of concept. Because if we imagine that in all the world, in all the country, we will use albumin for a long term of time, there is not enough albumin for everything, for everyone. So what we need is to develop some other anti-inflammatory agent that can be used everywhere without a logistic problem. Said that, what we have to reduce bacteria translocation, you know, up to now what we know is that the only way that we have to prevent SBP is to give norfloxacin. But norfloxacin was proved to be effective more than 20 years ago. And the last trial was published in 2018, but the last patient was included in 2014, so more than 7 years ago. This in microbiological term means a geological era, you know? So we don't know if norfloxacin is still active in preventing SBP in our patient. And we have some controversial data on rifaximin. So we need some controlled clinical study. We are performing one, liver hope, using the combination rifaximin statin in the prevention of decompensation in patients with cirrhosis.
Thank you, sir. Thank you so much. Yeah.
Okay, can I put some questions to the panelists? And the question to Dr. Rakhi Maiwal, doesn't beta blocker worsen the refractory ascites? And Professor Paolo was talking beta blockers in the prevention of refractory ascites. So what is your message on beta blockers in refractory ascites?
You know, the concern about the use of beta blocker in patients who already have developed refractory ascites came from the father of the beta blockers. So it is a concern that we should consider it very seriously. Even here, we have not a controlled clinical trial.
Okay.
So what I suggest is the following. If the patient has refractory ascites and develop arterial hypotension, AKI, SBP, stop it immediately. You can try to reintroduce after the recovery of the patient, but if the patient does not tolerate beta blocker, stop the beta blocker forever. And of course, you should address the patient to bundle ligation for the prevention of arterial bleeding.
Professor Paolo, another very important question. How do you monitor your patients of ascites who are on diuretics? So how often do you monitor their electrolytes, their creatinine? Are they just on a random basis?
Yeah. Difficult question, but you know, most of the diuretic adverse effect appears in the first 2 weeks after the start of diuretic treatment or after any increase of the dose of diuretics. So in this period, I suggest to monitor the lab every week.
Okay.
After 2 weeks, you can decide to monitor the lab every month.
Okay.
Dr. Malik here, I am the panelist. I have one question. In our resource-constrained countries, if we want to do the large volume paracentesis, and can we put an Devlin catheter for these patients as they put for the patients of cancer, they just put a catheter in and they are doing this paracentesis at home. So my question is from Dr. Pauli. Can you recommend for this Devlin catheter for this large volume paracentesis?
Thank you very much for the question. We have a bad experience with the catheter into the abdomen in cirrhotic patients. Our surgeon usually put catheter into the abdomen, and as a rule, they develop peritonitis within 2 weeks. So I recommend against the use of catheter.
Hello,
Yes,
one
can I-
question from my side. You said the beta blockers in refractory ascites, if you see hyperkalemia or if you see the AKI, then we should avoid beta blockers in these patients with refractory ascites.
Sorry, I cannot hear you well, Virendra. Can you repeat?
Yeah, so you said the beta blockers to be avoided in patients with the refractory ascites, those who have the hyperkalemia or those who develop AKI.
My general point of view is that if I have a patient with refractory ascites, true refractory ascites, and very at risk of bleeding, I will propose him or her band ligation, and I will stop beta blocker until we have some clear evidence that beta blocker are not harm in this patient.
Can I request Professor Katie Shinoy? He wanted to make some comment. Professor Shinoy, please. Professor Shinoy.
You are muted, Dr. Shinoy. You unmute first.
Okay. The long-term use of albumin, what do you think is the effect of etiology and the baseline CRP?
We have no data on this. We have no data on CRP. And in the trial, I presented with a roller patient with all type of etiology. But we excluded those who were receiving DAAs or those who were receive other antiviral drug for ACV-related cirrhosis.
With that, we come to an end because we are crossing time. So we'll stop here. Thank you, Dr. Paolo. Thank you all panelists, because there is a direction from Chief Dr. Anil Arora that we should stop just at the right time. Thank you very much.
But I think
Thank you. Thank you.
Bye-bye.
Applaud for Dr. Paoli. Yeah.
Bye, Raki.
Okay, sir.
Thank you.
Bye.
Thank you for this wonderful session on recent advances in management of refractory ascites. Now we move on to the next session. The session is current and future drug therapies for NASH. And for this, I would like to invite Professor S.P. Singh from SCB Medical College, Cuttack, and Dr. Ajay Duseja from PGI Chandigarh to take over and moderate the session and invite the speaker as well as the panelists. Dr. S.P. Singh and Dr. Duseja.
Dr. Singh, you can go ahead, unmute yourself. Good evening, everyone. And thanks for the opportunity for this mega meeting, Dr. Arora, Dr. Ashish, and the team.
Yeah, I thank the organizers for organizing such a wonderful meeting. And this is a very important session that is on NASH, management of NASH. To begin with, we'll have a lecture by Professor Mazen Nuruddin, and this will be followed by a panel discussion. And for the inaugural lecture on current and future drug therapy for NASH, we have a very, very eminent speaker, that is Professor Mazen Nuruddin, who is the founding director of the fatty liver program at the Cedar Sinai Medical Center. He doesn't need any introduction. This title itself says how much his commitment is there for this condition, NAFL, which is the #1 disease today in the world, liver disease in the world. So without much ado, his introduction would take another 5 minutes. I won't go into that. Needless to say, he has numerous presentations, publications on NAFL, and he's completely dedicated to NAFL research. Professor Nuruddin, please.
Thank you very much, Professor Singh. Let me share my screen. I would like to thank Professor Arora for the kind invitation, and it's a true honor and privilege to be here among colleagues in India and the region from Asia. Actually, my last trip before COVID was to India before I returned to the United States. And then I recently got fortunate and traveled again, but I got stuck for a while, and it was nice to travel to India before I got stuck in the United States. Anyways, let's dig deep to NASH. It's a talk for 20 minutes, but usually for update on NASH therapies, you need 5 hours. So let me try to do that in 20 minutes. Buckle up, try to focus because there's a lot, but I'll try to sum it up in 20 minutes in a meaningful way. So current and future therapies for NASH. We'll start with weight loss. Most patients with non-alcoholic fatty liver disease and NASH are overweight. Nevertheless, some patients are lean NASH, especially in your region of the world. Even those, they can benefit from some weight loss. The rule of thumb that to have NASH resolution, you need about 7% of weight loss. To have fibrosis improvement, you need 10% of weight loss. The odds of success are on the low side, and that's why we always try to have additional pharmacological therapies. I always say the lean NASH are more difficult to treat because there is not much room for improvement because they're almost at their ideal weight. The type of food matters as well, and they have multiple studies on that. The US guidelines talk about the Mediterranean diet because multiple studies have been done about that diet. Coffee, as all know, is very helpful. We publish data, Stephen Harrison published data on steatosis and fibrosis, and that coffee reversed that. What's hot and sexy right now is the low carb diet as well as the intermittent fasting that our patients are following. In terms of the bad, Shira Sagi from Israel published data initially on the red meat and processed red meat. We collaborated with her, published this paper in Hepatology that red meat and processed red meat correlated with NASH cirrhosis. Even chicken correlated with NAFLD, and it's probably due to the way like we raise our chicken and meat nowadays. Cholesterol correlated with NAFLD with cirrhosis and fiber were protective. We also know about the high corn syrup, sodas, and other type of food. So a detailed diet as well as nutritionist advice are always welcome and recommended. And I do have a nutritionist in my program that every single patient go talk to her after my visit. Professor Arun Sanyal and the NASH CRN that we all know about, which is a multi-center US study now about 15, 20 years, in collaboration, published this study about vitamin and pioglitazone, the PEVN study in the New England Journal. And here I want you to look at the left first panel. This is the histological overall improvement, and vitamin E in blue showed more improvement compared to pioglitazone, the placebo. And this is why vitamin E was recommended for non-cirrhotic, non-diabetic NASH patients that they are biopsy proven in the AASLD guidance. Kinkusi, followed by other studies using pioglitazone for diabetics, and he showed that pioglitazone improved histology in diabetics and non-diabetics. Here you see the 2-point NASH improvement in histology, and we'll talk about histology in a second. And next to it, NASH resolution, which is harder to achieve in diabetics patients with NASH, and those are all biopsy proven. So vitamin E and pioglitazones, they are recommended for NASH patients that they are biopsy proven in the AASLD guidance. Vitamin E recommended only for non-diabetics, pioglitazone for diabetics and non-diabetics. None of them are recommended for cirrhotics because no studies were done for cirrhotics. Nevertheless, the talk about side effects, maybe not as confirmed as we like, but we have this up in the horizon, such as the hemorrhagic stroke, cardiovascular side effects with vitamin E and prostate cancer, pioglitazone weight gain that none of the patients like it, osteoporosis and bladder cancer have limited their use. And thus many of our patients go into clinical trials if they don't want to use pioglitazone and vitamin E, that they are currently off-label, recommended in the guidance of many societies. So that's what we have available in hand nowadays: diet, vitamin E, pioglitazone in general, and we'll talk about what has been approved in India with our studies in the next steps. But let me land this scape for you here in the spectrum of NAFLD. Nowadays, what we have in our clinical studies, that patients with NASH and F2 and F3 enter into registry studies. The reason of choosing F2 and F3 is because F2 and F3 patients shows that F2 and higher are the patients prone to morbidity and mortalities. Of course, cirrhosis patients are a different bucket of patients that are proven to be challenging, and many patients actually, or many studies have failed in cirrhotic patients. Also, let's establish the principle of phase 3 registry studies. You have two outcomes that the FDA or the European agency that will let you have your drug approval. So the NASH resolution, as you know, the NASH CRN, Clinical Research Network Histology Score, consists of steatosis, inflammation, and ballooning up to 8 points. And to have NASH resolution, you need to get inflammation 0 to 1, ballooning 0, and no steatosis. So either you get NASH resolution without fibrosis worsening, or fibrosis improvement by one stage without worsening of steatohepatitis. Recently, the FDA updated the guidelines and they said, actually, you can get both of them, which makes sense. So either NASH resolution or fibrosis improvement, or both of them for phase 3 registry trials. So this is a scheme of what the landscape looked like. Here you have drugs in this big balloon that target de novo lipogenesis, or the target lipotoxicity, inflammation, or target fibrosis. You have some drugs in the phase 3 and some in the phase 2, and that's what we're going to talk about. The phase 3 studies, or the list, unfortunately keeps shrinking. We had many failures recently, but what we have still surviving, obeticholic acid, we'll talk about it in a second, which is FXR agonist. We have resmetirom, very promising thyroid hormone receptor agonist. We have belipectin, which is the only drug now probably for cirrhosis. There are other entering, an RM-call, which is SCD inhibitor, which I'll show you what it is in a second, but now it's kind of in a holding pattern in phase 3. We'll see what they do. Let's talk about the Regenerate study, which is the obeticholic acid, and I want you to look at the left, which is the F2, F3 patients. On the left, you see that they met one of the primary endpoints, which is fibrosis improvement. So in orange, the 25 milligram, 23% of patients compared to placebo, 12% met the primary endpoint, which was statistically significant. Again, fibrosis improvement, no worsening of steatohepatitis. On the right of that left side, they did not meet NASH resolution. But again, you need to meet only one of them. The problem, though, there was itching in these patients up to 50%, and there was worsening of LDL. We have heard about also safety signal, and is sitting with the FDA to determine the final fate of this drug, and they might ask them for more safety signal, and we'll see if this drug get approval or not. So it's still, the trial is still ongoing, and the FDA decision is pending. So this is a phase 3. The resmetirom, the phase 3 is still ongoing. I'm showing you the phase 2 trial published in Lancet. This is a thyroid hormone receptor. The thyroid hormone receptors, there are some in the liver that regulate glucose and lipid metabolism. And in this study here, we're showing you the MRI fat fraction results. On the left, the relative reduction, excellent, as well on the right, the absolute reduction. What's important in that study, the phase 2 study, that you have the phase 3 ongoing, they had also histology. So they had 2-point reduction in NASH score that met statistical significance. They had NASH resolution, which is harder, also met statistical difference. Fibrosis was not statistically significant. Nevertheless, they had other fibrosis markers that met the statistical significance. So if this replicates in phase 3, we're in a good hand and we'll have fibrosis improvement. We'll have drug approval. This trial is expected to be approved or to be read in a year or two from now. Hopefully it'll be approved. Bilapectin is a drug which is a galactin-3 inhibitor. The exact mechanism is not known. Professor Chalasani led this study that we were part of it. So this study was done on NASH cirrhotic patients. So this is one of very few studies done in NASH cirrhotics. It enrolled patients with portal hypertension, and there were 2 doses. The study did not meet its primary endpoint of changing portal pressures. However, in the 2 milligram dose, in a sub-analysis, in those that they did not have varices at baseline, again, did not have varices at baseline, they met the primary endpoint of changing portal pressure. And there was a very important finding that they did not develop varices. So the phase 2b/3 adaptive design that is ongoing now is looking into prevention of development of varices. So everyone with NASH cirrhotic enters without varices, and we have to prevent varices development. Very important study. Hopefully it'll pan out to help our patients. Moving on to phase 2, and there are so many of them. But let's again establish the principles. The outcomes, or the primary efficacy endpoints. MRI fat fraction, which measure fat or quantify fat in the liver, has turned to be one of the most attractive endpoints or the most used endpoints. And we usually look at this concept, more than 30% relative reduction. So we look at the percentage of patients with more than 30% relative reduction. So you will hear us talking about this. There's absolute reduction, there is relative reduction. We also usually couple that with ALT reduction. As you know, more than 17 units drop has correlated with histological response in NASH patients. So it's helpful to see these endpoints along side to side in phase 2 proof of concept study, especially the early ones, 2A, in a drug that reduces fat. This is an American show with families fighting on a kingdom that they want to take over. And this is the concept of NASH drugs, who is going to take over first. But I think they all have to live together in a combination life. But those are the classes of the drugs. So let's talk about them. We're going to talk about the FGFs and the FXRs. And they work intimately in the intestines as well as the liver to regulate the FGF and FXRs receptors to regulate glucose and lipid metabolism in the liver. You probably heard the bad news about the NGM, which is aldafermin, FGF19. They had multiple studies published in Hep, Lancet, great PDFF reduction, great single arm biopsy results, positive results, no placebo. But then they, in this study, which was 24-week studies, biopsy study, they had a primary endpoint of fibrosis improvement that they did not meet. Focus here, pay attention. What happened is, in their secondary endpoint, they met NASH resolution, which was statistically significant. So usually this NASH resolution is one of the primary endpoint. If you meet this or this, you get approval. They did not do that here, and the study was negative, unfortunately. And a lot of people said, why you don't continue? You have NASH resolution. But the company had other assets and other disease. And because they got scared of semaglutide that I will show you, their NASH resolution in a few slides, they said, we're not continuing NASH resolution is not enough for us. So this got terminated. of rifaximin is FGF21. The study published in Nature Medicine, outstanding results. Look at the MRI-PDFF absolute reduction and relative reduction. But what I want to point you to is the 30% reduction here in the table. Look at the various doses and look at the 70 milligram dose. More than 30% reduction, 100% of patients achieve that. More than 50% reduction, 93% of patients achieve that. More than 70% of patients, 80% of patients achieve that. This is unprecedented before, and we have not seen that before. They also had changes in fibrosis markers, which was very promising. Indeed, Stephen Harrison presented in EASL recently an extension arm, which was cirrhotic arms, which was very interesting, actually. In this extension arm, he had cirrhotics that they were biopsy proven. He only had 20 cirrhotics that in the treatment arm and 10 on the placebo arm. And what he showed is before and after therapy, that 33% of them had fibrosis improvement within short duration, which is 16 weeks, and they had NASH resolution and the placebo had 0. This is a very short time to have fibrosis improvement and a very small cohort, but it's still very encouraging. We have to interpret that with caution and see the results, but this is very promising, and we'll see what the future holds in these cirrhotic patients. This is by Akiro, and they're going for cirrhotic cohort. We'll see what they do. BMS has FGF21. Professor Sanyal published this in the Lancet. This is their MRI-PDFF data on the FGF. It's going to read on F3 and F4 patients soon, so we'll see the results on that as well. Moving on to the FXRs. This is Silofexor by Gilead. It's an okay drug. They use it in combination with the ACC inhibitor. We'll show you that in a second. But here, this is your 30% reduction. So in week 24, focus on the right, on the higher dose, up to 39% of patients achieved reduction on MRI-PDFF. A very good drug for combination. This is a little bit on the low bar side, but it's one of their combo drugs. Tropifexor by Novartis had many positive results, but Professor Sanyal presented this interesting data recently in one of the meetings. What was interesting that patients lose weight on this FXR, and you see the MRI-PDFF data, excellent relative reduction here on MRI-PDFF. But interestingly, on the biopsy, despite adequate duration, they did not achieve NASH resolution. They did not achieve fibrosis improvement. So in this study, there was a disconnect between MRI-PDFF and histology, although meta-analysis showed that MRI-PDFF correlate with histology and left us scratching our head. I think they will continue, but we'll see what the future design, especially with negative histology on this FXR. Now we're moving from the FXR and FGF to fat synthesis inhibitors. And it is this balloon, and this balloon usually responsible for de novo lipogenesis, and these enzymes make fat in the liver. So if you hit any of these enzymes, you suppress the fat. So ACC inhibitor, SCD1, you see the FASN here. If you suppress these enzymes and you inhibit them, you will achieve decreasing fat in the liver. The ACC inhibitors, there are 2 of them, one by Pfizer, which is this drug in a 16-week trial. This is the MRI-PDFF results. And look at the highest dose. 90% of patients achieve 30% reduction. Very high results. And the problem with the ACC inhibitor, one of the side effects that you have hypertriglyceridemia that they're trying to mitigate by combining with other drugs. Gilead has their Friscostat as ACC inhibitor. On the right, I'll show you the 30% reduction. 48% of patients achieve 30% reduction in 12 weeks. I showed you their FXR was only 39% of patients in a longer duration, 24 weeks. So they combine their ACC inhibitor with their FXR. So they use these two drugs in their combination. Remember this drug, Ferriscostat with their Cilofexor, FXR, Gilead. I'll show you a triple combo by Gilead very soon, which is the semaglutide by Novo, and that's what they're going with. Again, ACC inhibitor, FXR, they're gonna combine it with a GLP-1 very soon. Finally, this drug that is sitting waiting for F3, SCD inhibitor, which is another enzymes, showed a great MRI-PDFF reduction. The histology also they met was very marginal with a very low placebo. It's a little bit risky because the placebo is usually higher. So they met NASH resolution in this phase 2 study, not published yet. We're waiting them to publish it as well as their phase 3. And this is the last fast synthesis inhibitor, fast inhibitor on the tail end of that cycle, published in Gastro, reduced MRI-PDFF, ALT, and AST in 12 weeks, and we're going for their phase 2B soon. GLP-1, very exciting, one of the diabetes medication. The concept started with liraglutide. You all heard about the lean study published in Lancet, investigator-initiated study, small, in the very far left, NASH resolution, 39% compared to 9%, which led to the concept of the New England Journal paper, semaglutide 72-week study. Phil Newsom presented these data. I want you to look at the third panel, which is the dark blue F2, F3 patients. 59% achieved NASH resolution. Excellent compared to the placebo, the highest NASH resolution we have seen. Unfortunately, the slides show you again the third panel, the dark blue, 42% achieved fibrosis improvement, but the placebo was high 32%, and that was statistically not significant. So they did not achieve fibrosis improvement, but semaglutide now is in phase 3. Thyroid hormone receptors that are in phase 2, I showed you resmetirom in phase 3 now. There's one in phase 2, which is Viking in a phase 2. They showed MRI-PDFF reduction, which was excellent, very small study. We're looking into their phase 2B now. We'll see where it goes. PPARs, very attractive agent, very potent. You know, PO is now like one in the guidelines, but let's see. This is a very attractive agent. It's pan-PPAR called lanifibranor in a very short histological study, which was 2A, 2B, 24 study. They achieved all endpoints that the FDA talking about. NASH resolution 45% compared to 19%, fibrosis improvement 42% compared to 24%, and both of them 31%, which is harder compared to 7%. They are going for phase 3, very attractive agent, achieved 3 endpoints within a short time. Weight gain was an issue. Saroglitazar, that you all know, approved in India, which is the first NASH approved drug in the world. In the United States, Indiana University, Dr. Chalasani's site, we worked with him on this study in a phase 2A. It did achieve ALT and MRI-PDFF improvement. I know in India that also there was a histological study that achieved NASH resolution, and I know it's approved in India, and it's alpha delta drug that is being used. Combo therapy is very important. I'm going to mention this to you to finish the talk. This is SEMA trial plus Silo and Ferriscostat, and this is open label by Gilead. So SEMA plus Ferris, SEMA Silo higher and the triple therapy. And look here at the triple therapy SEMA here, and the very first last column, SEMA plus FER plus Silo, and I want to show you the table, 30%, 92% compared to SEMA alone, 80% of patients. 50% of patient fat fraction, 85%. So it's very promising to have this combination. Indeed, if you look at the FibroScan improvement on the triple therapy was more than SEMA alone, and this is very promising, and they're going with a phase 2B to assess this triple therapy as a drug. So in conclusion, NASH therapies have made great progress. The non-invasive testing such as MRI, PDFF, and other biomarkers ELF, and other PRO-C3 have helped in the proof of concept studies. Thyroid hormone receptors, PPARs, and GLP seem to be leading the way. Antifibrotics are targeting the more difficult group cirrhotics, but we're having great challenges in that group, and combination will be likely the way to go. With that, I'd like to thank everyone. The same way we got to hepatitis C treatment, I'm hoping to get to NASH eventually and get to the finish line. Thank you very much.
Thank you, Professor Mason. I think that was really wonderful talk. I think in 20 minutes, you have covered such a vast area of the therapeutics of NASH. So I think before we go on to some discussion on this, let me first invite the panelists of this session. Can I request Dr. Mason to stop sharing your screen?
Yes, sir.
Yeah. So the panelists for this session are Dr. Barun Srestha from Bharatpur, Nepal. Then we have Professor Zegam Abbas from Karachi, Pakistan, Dr. Gulnara from Azerbaijan, Dr. Ravina Bhavani from University of Malaya, Kuala Lumpur, and Dr. Manoj Sahu from Bhubaneswar, India. I'll request all of you to kindly switch on your videos and audios. And before I think they start, asking you the questions and we take questions from the chat box, let me just start the ball rolling. I think it's very nice that you touched saroglitazar, which is, we are lucky here in India, which is, at least we have one drug which is approved by a regulatory agency. And the problems of pioglitazone which are associated. So we have vitamin E and at least saro, which are so considered, safe drugs for these patients. My question to you would be about the FXR agonist and the issues which are associated with FXR, the issue of dyslipidemia and the issue of pruritus. And that could be one of the reasons that it has still not been approved by FDA. So what is your thought, or what are your thoughts about the newer, what they call the structurally optimized, FXR agonists, and the recent study we had in J. Hepato on MT409, which, tend to get rid of or tend to take care of, this pruritus and the, decreasing HDL, increasing LDL issue with FXR. So this will be the first question. And then, as I said, I'll open this to the panelists and we'll take more questions.
Yeah, you're right. The newer agents are thought to reduce the side effects. Unfortunately, we're still seeing a little bit itching, so it's not going away 100%. We started seeing medication of the LDL and HDL, so hopefully that will kind of help us in the FXR. Nevertheless, if you really look at other agents, you have ACC inhibitors reduce the fat significantly in the liver, and they're very attractive agents. They have hypertriglyceridemia issue though. So I think a lot of us started accepting that we might have get this lipidemia signal with some of the drugs that we have to medicate with other anti-dyslipidemic agents, or by combining it with other drugs, like for instance, resmetirom reduce the lipid signal, and hopefully combining drugs or using anti-dyslipidemic agents with the combination will reduce that FXR agonist signal.
May I ask a question, Professor Nuruddin?
Yes, sir.
Yes, nice presentation. Yes. Thank you very much. I just want to know that leaky gut syndrome and the gut microbiome, because we know the role of gut microbiome in causing NASH and the role of endotoxin. So why don't we concentrate on the root cause, which is the leaky gut? Are there any studies that are addressing this issue? And have they shown any improvement in the NASH score and histopathology and fibrosis?
Yeah, so I would say in NASH, it's an infancy. In terms of, I would say the leaky gut and microbiome is very, very important in NASH. I won't say it's the root cause, I'll say it's one of the causes. NASH, as you know, is complex disease. There's genetic components that, we did not talk about today because it's a therapeutic talk. There are lipid, there is food, nutrition, environment, and microbiome. There are studies that look at different microbiome in terms of NASH and disease severity, and those have been published. Recent data from the aldafermin, the NGM therapy showed changes in microbiome after therapy, and that was the first longitudinal study showing changes in microbiome composition after therapy. In terms of using microbiome itself, like fecal transplant and NASH and stuff like that, I think the studies have been small, negative, and shy. And I do agree with you that we need more of that. And this is a very important area and very important question. So we need to expand on that.
Thank you.
Ajay, can I ask a question?
Yeah, please go ahead.
Dr. Mazen, excellent presentation. My question is basic. You see, when you talk of treatment of non-alcoholic fatty liver disease, you exclude fat. You basically try to treat NASH, not the presence of fat in the liver. And when you're assessing the efficacy of the drugs, you are looking at MD-PDF, which is MRI-PDFF, which is practically looking at the fat. So why this dichotomy? It's pretty bewildering and exacerbating. You're looking only on fat when you do not even include it as an assessment criteria.
Outstanding question. So for the sake of time, showing all these studies, I did not put the inclusion and exclusion criteria. So in phase 3 studies that we showed you, they do biopsy, they look at fat and NASH, and they include NASH and F2 and F3 usually. With the phase 2A, the inclusion criteria, usually they try to get NASH phenotype because they don't want to do biopsy. So they get the fat and they enrich their study with NASH phenotype like. So a lot of them will have elevated ALT, elevated FibroScan that resembles the NASH and F1 and F2 and F3 like patients, but without the biopsy. And it's thought that if we reduce the fat plus the inflammation on PDFF, you're likely reducing the NASH. That because MRI PDFF meta-analysis showed if we reduce it, it correlates with biopsy. But this is a very important point, and I can go to it into details because we still don't know if MRI PDFF correlates 100% with histology, and we had some failures in that space because of that. So that's an excellent point. But most of these phase 2As are NASH phenotype enriched like patients.
Okay, any questions from the panelists before I take some questions from the chat box? Dr. Veena, Dr. Sahu. Okay. So let me ask you a question, Professor Mazen. I think that the 2 questions from the chat box. One is about, people are asking about, the issue of liver biopsy in patients with fatty liver disease. Across the globe, and at least in our country, the acceptability for liver biopsy is, poor. So people are relying more and more on the non-invasive assessment. So what is your thinking about, using the pharmacological treatment and, following them up with the non-invasive assessment rather than, histology? That's the first question.
I'm all up for that. You're talking to the right person. So everyone is absolutely right. So there is the inter and intra-observer variability. We recently did webinar in at the ASLD, Vlad Radziu moderated, and we had 3 talks on that in particular. We're just trying to convince the FDA it's time to move away and from liver biopsy in phase 3 registry. However, it's a long road that the FDA wants us to take. I mean, they have a point. You have to show the correlation with outcomes, improvement, and all that. So there's regulatory pathway to move away with liver biopsy in phase 3 trials. What you and I and everyone on this panel do in real life, we actually don't do serial biopsies. we use our clinical sense between ALT and FibroScan and other biomarkers to follow these patients. So we're trying to tell them is like, now we have good, and this is a talk by itself. We have good evidence, and that's what we do in clinic every day. So let's try to move away from biopsies. So I hope that will be the future or the near future, but the regulators want to sit down and see the evidence and get convinced.
See, the next question is about the length of using, these drugs as and when these are approved. So we have Saro in the country, and our practice, whenever we start using this, we give it for 1 year, and that is our histology-based study, which multi-center study, which we had done in India. But then as and when these drugs are approved, say in US by FDA, the other drugs, I mean, lifestyle interventions obviously would continue for lifelong. I mean, this is a lifestyle disease. But what do you think would be the appropriate length of using, these drugs? That's another question in the chat box. Yeah.
Yeah, I mean, we still are shy talking about this. You have the advantage that it's approved in your country. I think the minimum, but we have discussed that in our forums and multiple conferences. I think the least we have to do is trials include F2 and F3 patients. So we have to move away from that phase, at least to F1, preferably to F0. If the enzymes normalize, that's even better. Then you continue lifestyle intervention for the rest of their life. Some people want to go all the way until inflammation and fats resolve. Some people want to go from F2, F3, F2 to F0, and then continue with a drug that is more metabolic. For instance, GLP-1s. Now, the problem with GLP-1s, the drugs are very expensive. Some are injectables. So we have to find a happy medium. But I will say the minimum, to me, if you ask me, I think we have to take the fibrosis down, normalize the ALT, and then continue lifestyle intervention. But that field has to be shaped once we have effective drugs that you do have already in your country.
Thank you. So Dr. Ravina, Dr. Sahu, any thoughts, or Dr. Shrestha, or I continue with some more questions?
Ajay, can I ask a question?
Yeah, please go ahead, Dr.
Dr. Mazen, again, coming back to the basic question raised by Professor Zagam Abbas, what we are trying to do in treating NASH, and that is precisely the reason that till even after decades of looking for a therapy, we have found nothing. Because we are missing the bus. We are trying to catch hold of the animal by the tail, missing the head and body. The problem lies at the level of intake of the food, at the level of the brain, gut hormones, which we are totally ignoring, and the GI tract. So by the time you have a problem landing in the liver in terms of NASH and the consequences of metabolic syndrome, we have already missed the bus. That is the reason we have nothing till date. So why not concentrate on, say, appetite suppressant, antigrelin, and that something like semaglutide? So why don't we concentrate on that rather than looking at the fag end of the problem?
I mean, I agree. We just need more research and more people to explore the microbiome. It's not an easy, complex area. I'll give you an example. In alcohol, and Shwani is going to talk about this, one of the things that have been discovered, the fungal composition in alcoholic patients, we still don't know the fungal changes in non-alcoholic steatohepatitis. So there are a lot of weird organisms and creatures that we don't know that happens in NASH. And I think we should go to one of these causes and explore them. Genetics, why some lean people get that, some people don't get that. I mean, genetic modifications is very important. We do have people that they are obese and they don't get NAFLD or NASH, and we have lean people that get NAFLD and NASH. So those are all genetics plus environment factor. And I think we are in infancy in this field. And there are research ongoing. We do some of it and all other people. And I think we just need to expedite that. As you know, the pharmaceutical companies are focused on drug, and that's why there's money into that. And that's why it's going really fast and that way. But I cannot agree more with you guys that this is area that needs to be explored way further.
Okay, we have last 2 minutes to finish. Dr. Ravina, you want to say something? Yeah, please go ahead.
Yes, Dr. Ajay. Thank
Yeah,
you.
please. Yeah.
Professor Nuruddin, thank you very much. That was a great talk. I would just like to comment that I feel that despite the emergence of encouraging data on new therapies in NASH, I still think that exercise and dietary modification, emphasis on calorie and carbohydrate restriction should definitely go hand in hand. But do you think that these medical therapies may be far superior than lifestyle changes? Do you think it can work without lifestyle changes?
I think they will work without lifestyle changes. I think they will fail without lifestyle changes eventually. So that goes back to the question that when do you stop them? If you stop them and the patient doesn't continue lifestyle changes, he will go back to NASH and fibrosis. I 100% agree with you that all patients have to go to lifestyle changes and exercise and add the medications to that. The very first slide I showed you, to get fibrosis improvement, you need 10%. In the Romero-Gomez gastroenterology paper, only 10% of patients were able to get to that level. So I always look at it from the standpoint is if I have F3 patients, about 20% of them get to cirrhosis. That's the data within 2.5 years, and only 10% can lose weight. I don't want to just count on weight loss and exercise. It's essential. It's the backbone, but I don't want to count on 90% failure. So if I have a drug that can help me, I will fill my patient's ear with the weight loss and exercise, but add something to it if I can. But the principle, I 100% agree with you.
Yeah, Dr. Sahu, you want to say something?
Thank you for a great presentation.
Thank you.
So any pharmacotherapy for lean NASH? So any expected pharmacotherapy, any drug trial for lean NASH, management of lean NASH?
Yeah, I mean, it's you guys know more than us about lean NASH. I do have in Los Angeles a diverse population. I do have Indian patients. I do have Asian patients. I think PPARs are very attractive agents for lean NAFLD and NASH. I'll give you an example, like GLP-1s, when they came out, and I said, if patients lose weight on GLP-1s, what you're going to do for the lean NAFLD and NASH? So they were not so attractive for me. So drugs like PPARs are very attractive for lean NAFLD and NASH, and that's why you have saroglitazar approved in your country. And it's an attractive agent. I think the other one will be very attractive for the lean NAFLD and NASH, a drug like resmetirom that is expected to be approved in the United States. So those are two drugs that come first to mind in lean NAFLD and NASH. And I think, I don't know, maybe I can learn from you guys what you do in terms of diet and exercise for these patients. I'm overweight, so I find it hard to talk to my lean patients about losing weight, and usually I put them in pharmacological therapy.
Dr. Mason, I think that was wonderful. We are out of time, and it was very nice to see you again after that Ahmedabad, NASH meeting, and hope to see you soon in person again. So I think I'd like to close this session. Dr. S.P. Singh would like to say anything before we close this session?
I think we are running out of time. So no more questions from me.
Okay. Thank you for having me.
Thank you very much. Thank you. Bye-bye, Dr. Mason. Very nice. Thank you. We close this session and thank the speaker and all the panelists for a wonderful discussion. Thank you all.
Thank you, Dr. Ajay and Dr. S.P. Singh for moderating the session. So now we move on to the next session, that is advances in management of non-resectable HCC. And for this, I would like to invite the moderators, Dr. Vivek Anand Saraswat from Sanjay Gandhi PGI Lucknow, who is my teacher, and also Dr. K. Narayan Swamy, who is a renowned gastroenterologist from Chennai. So I hand over to Dr. Saraswat and Dr. K. Narayan Swamy.
Thank you very much, Ashish.
Good evening to everyone and welcome to the third session in what has been so far a scintillating evening. Must compliment the organizing team. Anil and Ashish have done a great job in choosing relevant and important topics as well as some excellent speakers. So now in this sequence, the third topic is just as important as refractory ascites and NASH, although we may be not encountering it as commonly. And this is advances in the management of non-resectable hepatocellular carcinoma. I think overall, especially in the northern and western parts of our country and in tertiary centers, we are seeing an increasing number of patients with HCC, particularly those who are unresectable, those who have large tumors or who cannot afford more advanced therapies like transplant and etc. So with this background, and yes, Dr. Narayanaswamy has also joined us. Good evening. What I'll do is I'll briefly introduce the speaker and the topic we've already spoken about. And I'll request Dr. Narayanaswamy to introduce the panelists once the formal presentation is completed. And then we will have the question answer session. So without much ado, it's a great pleasure for me to welcome Professor Francis Yao for this clinics in hepatobiliary diseases. Professor Yao is the professor of clinical medicine and surgery, as well as director of the Department of Hepatology and medical director of the liver transplantation program at the University of California in San Francisco. He's a well-known and a highly reputed authority in the field of HCC management with a large number of publications and original work to his credit. And we look forward to hearing his views on the advances in management of non-resectable hepatocellular carcinoma. Professor Yao, please.
Thank you very much for the nice introduction. Let me share the screen here. And yeah, okay, thank you very much. I'd like to thank Dr. Aurora and the organizers for this very kind invitation. I'm being assigned to speak on, to try to review some groundbreaking publications in the last 2 years, focusing on the treatment of more advanced stage HCC. As you look at the latest EASL treatment guidelines using the modified BCLC staging system, what we're focusing on is the stage C patients, and we have seen major advances in the management in this particular group of patients. So just a brief summary about approved systemic therapies for HCC. This is an area that we have struggled for so many decades with no proven therapy for patients with advanced stage HCC, but we have now seen major advances in systemic therapy. As you're well aware, sorafenib, which is a multi-kinase inhibitor, was the first systemic therapy to demonstrate a survival benefit in advanced stage HCC. And then since it was approved for these patients, we went through a period of 7-8 years when multiple clinical trials have failed to show any significant benefit in other systemic therapies. However, in the last few years, we have seen a number of additional therapies that are now being approved, starting with these 3 additional tyrosine kinase or multi-kinase inhibitor, lenvatinib in the REFLECT trial, second-line therapy regorafenib in the RESOURCE trial, cabozantinib in the CELESTIAL trial. At the same time, very promising data on immune checkpoint inhibitors have really emerged and quickly shifted the direction of our research to immunotherapy. Nivolumab which is a PD-1 inhibitor, and also pembrolizumab, another PD-1 inhibitor, have received accelerated approval in the US for HCC after only phase 1 and phase 2 trials. Ramucirumab, I believe, is approved also in India, is a monoclonal antibody against VEGFR2, published in this study, the REACH2 trial, and is approved for a second-line therapy in the subgroup with alpha-fetoprotein at least 400. More recently, we see combination therapy, revolutionize our approach to patients with advanced stage HCC. Combination of atezolizumab and bevacizumab in the IMbrave study is now becoming a new benchmark of systemic therapy. Another combination, nivolumab and ipilimumab in the Checkmate 40 study, has also been approved in the US as second-line therapy. So just quickly go over some of the basic principles behind immune checkpoint blockade in HCC. You see in this schematic diagram the antigen presenting cell, the CD8 positive T cell, and also the tumor. Now, PD-1 is a receptor that serves as a brake for the immune response. The antigen presenting cells or the tumor cells express interferon gamma-induced PDL1 and PDL2 that binds to PD-1 and that attenuates the anti-tumor response. This is known as immune escape of tumor cells from the activated T cells. So if you block the PD-1 inhibitor, or if you also block the PDL1 or PDL2 or CTL4, you basically remove the brake on this immune system and restore the ability of T cells to attack the tumor cell by releasing molecules such as perforin, genzyme, interferon gamma, and other cytokines. So that's the principle behind immune checkpoint therapy. As I mentioned, combination therapy has revolutionized the approach to treating HCC. The first combination therapy approved in the US is atezolizumab, which is an anti-PD-L1 inhibitor, and bevacizumab, which is a monoclonal antibody against VEGF in the IMbrave study. I will also talk about the other combination therapy, nivolumab plus ipilimumab, the CTL4 inhibitor in the Checkmate 40 study. And finally, I will touch on a very recently published study involving sintilimab, which is anti-PD-1 inhibitor, with a compound very similar to bevacizumab in the Orient 32 trial. So this is the first study, the IMbrave study, atezolizumab, published by Dr. Richard Finn and his colleagues in the New England Journal of Medicine last year. So this is a phase 3 randomized control trial comparing atezolizumab with sorafenib. The key eligibility criteria include locally advanced or metastatic unresectable HCC, patients who had no prior systemic therapy, good functional status, ECOG 0 or 1. So a total of 501 patients were randomized 2-to-1 ratio to atezolizumab 1200 milligrams and bevacizumab, which is weight-based 15 milligrams per kilogram, given IV every 3 weeks versus sorafenib 400 milligrams twice a day. The primary endpoints are overall survival or progression-free survival. They used the RECIST version 1.1 with independent review facility. Secondary endpoints, there are many of those, but the key one is the ongoing or overall objective response, using both the RECIST 1.1 and also the HCC modified RECIST criteria. So the primary endpoints are overall patient survival and also progression-free survival. So you can see in terms of overall survival, the atezolizumab group performed significantly better with an overall survival 85% at 6 months versus 72% at 6 months in the sorafenib group. So the difference was statistically significant. In terms of progression-free survival, you can see that the median progression-free survival also significantly longer at 6.8 months in the atezobev group versus 4.3 months in the sorafenib group. So other secondary endpoints, you can see here the confirmed objective response, one of the major secondary endpoints. The overall confirmed objective response was 27% in the atezobev group versus 12% in the sorafenib group. Now, this 27% overall confirmed objective response is the highest reported rate in all phase 3 trials for HCC to date. And other secondary endpoints, the atezobev group also had a significantly higher disease control rate and ongoing objective response at the time of the data cutoff. So these endpoints, clearly show that atezobev significantly outperforms sorafenib. In terms of adverse events, so first looking at severe adverse events, we call it grade 3 or 4, similar rates between the two groups. I'd like to draw your attention to grade 5 event, which means fatal adverse events that resulted in death in about 5% in the atezobev group. And so some of the causes include GI hemorrhage, esophageal variceal bleeding, and subarachnoid hemorrhage. So bleeding is an important consideration. So it's well known that VEGF inhibitors can be associated with increased risk of bleeding. The reason for this is not entirely clear, but it's possible, possibly because of alterations in the endothelial function. So these observations highlight the importance of assessing and also minimizing the risk of bleeding in these patients, such as including endoscopy in your assessment, treating the varices prior to initiating the combination therapy. You can also see that a slightly higher percentage of patients receiving atezobev had serious adverse events or SAE, or required discontinuation of therapy. So this combination therapy is not without risks. Now, another important consideration is that atezobev delayed the time to deterioration of patient-reported quality of life compared to sorafenib. You can see the difference, 3.6 months in the sorafenib group versus over 11 months for the atezobev group. So some of the key points that's relevant to clinical practice, the atezobev combination is now becoming the new benchmark for first-line therapy for unresectable or advanced HCC in patients with good liver function or Charles A cirrhosis, have good functional status. This is presented in the very recently published EASL position paper by Professor Bruch in the Journal of Hepatology. A more practical issue here is that before you start atezobev, it's important for us to realize that we should perform upper endoscopy within 6 months to exclude high risk of bleeding and treating varices if they have significant problems there, and obliterating prior to initiation of therapy. If atezobev is not available or patients could not tolerate this combination, then letinib, sorafenib, they are alternative first-line therapy options. Okay, so second study I would like to present in review is the Orient 32 study comparing sintilimab plus a compound very similar to bevacizumab in patients in a randomized open-label phase 2/3 study for patients with unresectable HCC, published by Dr. Ran and colleagues from mainland China, and is published in Lancet Oncology just a couple months ago. So sintilimab plus bevacizumab is a randomized phase 3 mostly. It's a short phase 2 investigation prior to presenting all the phase 3 results. This is a study involving 50 sites in China. Sintilimab is a PD-1 inhibitor. Bevacizumab, is a compound very similar. It's a VEGF inhibitor. And this trial is to compare with sorafenib. The key eligibility criteria include locally advanced metastatic unresectable HCC. These are patients who had no prior systemic therapy. They have good functional status, ECOG 0 or 1. Total of 571 patients were randomized 2-to-1 ratio to sintilimab, 200 milligram bevacizumab, weight-based 15 milligram per kilogram, given intravenously every 3 weeks versus sorafenib, 400 milligrams twice a day. Keep in mind that this study is from mainland China. 94% of these patients have chronic hepatitis B. The design of this study is extremely similar to the IM-BRAVE study. The primary endpoints are overall survival and also progression-free survival based on RECIST version 1.1, also involving independent review. So primary endpoint, progression-free survival here, significantly longer in the combination therapy group at 4.6 months versus 2.8 months in the sorafenib group. The hazard ratio of 0.56, the difference was highly significant. Overall survival also favored the combination group with a hazard ratio of 0.57. In respect to secondary endpoints, the confirmed objective response rate was 21% in the combination group versus only 4% in the sorafenib group. Difference was highly significant. And the overall duration of response is also longer at 7 months in the combination group versus slightly under 3 months for the sorafenib group. So moving on to discuss about second-line therapy, this is definitely a very important topic. As you know, many patients already been treated with sorafenib. So many of them have tumor progression or failure to respond well to this treatment, and we need additional therapy to prolong survival. As already mentioned, a number of anti-angiogenic treatments have been approved as second-line therapy based on very high level 1 evidence, including the TKIs, regorafenib, and cabozantinib. Now, ramucirumab is a monoclonal antibody targeting VEGFR2, and that has also been approved in the second-line therapy for HCC after sorafenib for those with high AFP of at least 400. Now, a number of immune checkpoint inhibitors have received accelerated approval in the US based on more preliminary data in phase 1 and 2 studies. They include levodopa, pembrolizumab, and also combination of nivo and ipi. Nivo is a PD-1, and then ipi is a anti-CTLA-4 inhibitor. So I'm going to focus on talking about the immune checkpoint inhibitors and also ramucirumab. So this is the REACH2 trial using ramucirumab after sorafenib, published by Dr. Andrew Xu and colleagues in Lancet Oncology about 2 years ago. So this is a phase 3 randomized control trial comparing ramucirumab versus placebo in patients who were previously treated with sorafenib. Now, this is the REACH-2 trial. The first study, prior study, showed that the greatest benefit of ramucirumab was those with AFP that's high, at least 400. So in REACH-2, the key eligibility criteria include baseline AFP at least 400, BCLC B or C, good liver function, Child-Pugh A, patient with good functional status, ECOG 0 and 1, and who had received prior sorafenib. So a total of 292 patients were randomized 2-to-1 ratio to ramucirumab, 8 milligrams per kilogram every 2 weeks versus placebo. And the primary endpoint is overall survival. Secondary endpoints include progression-free survival, time to progression, and also objective response rate. So they observed a statistically significant survival benefit with ramucirumab based on a median overall survival 8.5 months in the treatment group versus 7.3 months in the placebo arm. So the difference is 1.2 months. The hazard ratio is 0.71. Looks like there's also a benefit of ramucirumab in terms of progression-free survival compared to placebo with a hazard ratio of 0.45. The next study I'd like to review is the Keynote 240 study evaluating pembrolizumab as second-line therapy, published by Richard Finn and colleagues in Journal of Clinical Oncology last year. So the Keynote 240 trial is a phase 3 randomized controlled trial comparing pembrolizumab versus placebo in patients who had progression after sorafenib or intolerance to sorafenib. The key eligibility criteria include failed sorafenib, progression or intolerance, BCLC B or C not amendable or refractory to local regional therapy, and patients with good functional status, ECOG 0 or 1. Total of 413 patients were randomly assigned 2-to-1 to pembrolizumab, 200 milligrams every 3 weeks versus placebo, each in combination with best supportive care. The primary endpoints are overall survival, progression-free survival based on RECIST version 1.1 with blinded independent central review. So all these studies are very carefully and well designed. So I would like to mention that this study has a pre-specified p-value of 0.0174 that's required for statistical significance in overall survival. With that in mind, the survival difference with pembrolizumab, the median survival of 13.9 months versus 10.6 months, fell just short of this requirement with a p-value of 0.0238. So just above this requirement to determine statistical significance. Now, pembrolizumab did confer a significant benefit in terms of progression-free survival, 19% versus 7% at 1 year, a p-value of 0.002. And the objective response rate was significantly higher also in the pembrolizumab group, 18.3% versus 4.4% in the placebo group. So the next study I'd like to review is the Checkmate 040 randomized controlled trial evaluating the safety of nivolumab plus ipilimumab, published by Thomas Yao and colleagues in JAMA Oncology this year. So this is a summary of the study design, including patients who progressed after sorafenib or were intolerant to sorafenib. So patients were randomized into 3 arms with different dose and frequency of nivolumab and ipilimumab. So arm A, nivo 1 milligram per kilogram, ipi 3 milligram per kilogram every 3 weeks, 4 doses, followed by nivo 240 milligrams every 2 weeks. Arm B, Nivo 3 per kilogram, Ipi 1 per kilogram every 3 weeks, 4 doses, followed by nivolumab 240 milligrams every 2 weeks. Arm C, nivolumab 3 per kilogram, ipilimumab 1 per kilogram every 6 weeks. And treatment was continued until disease progression or unacceptable toxicity. As you can see that patients in Arm A had the highest median overall survival, 23 months compared to 13 months in the other two groups. So treatment-related adverse is very interesting here that treatment-related severe adverse events, grade 3 or 4 was significantly higher in Arm A compared to the other two arms. More than half of the patients in Arm A require steroids for toxicity, including hepatitis. So the interesting observation in this and other studies on immune checkpoint inhibitor is that the greater drug toxicity seem to correlate with better response rate. On the basis of this study, this combination therapy with the dosing regimen of Arm A received accelerated approval in the US. You can see that the objective response rates are quite high, similar in the three arms, 31 to 32% based on RECIST 1.1 criteria, with response defined as a 30% reduction from baseline in a target lesion. So just a couple quick points here. We are now aware of the results of the Checkmate 459 trial, which is a phase 3 trial comparing levodopa with sorafenib that was not yet fully published. And the study actually failed to demonstrate a significantly better overall survival with nivolumab versus sorafenib. So the study was not designed as a non-inferiority trial. So nivolumab does not meet the requirement to be considered first-line therapy based on the results of this study. This is an important consideration that, all the studies, all the treatments that we discussed so far are really focused on patients with well-compensated or Child A cirrhosis, and the options are much more limited in patients with decompensated cirrhosis. Nevertheless, levodopa can be used in patients with mildly decompensated cirrhosis or Child B. This is an abstract presented by Professor Kudo and colleagues from the Checkmate 040 trial. 49 patients, Child B cirrhosis, about either Child B7 or B8. About half of these patients were sorafenib naive, and then the other half had either progression or intolerance to sorafenib. And they excluded patients who had active encephalopathy within 6 months or ascites requiring paracentesis within 3 months. And the results here show that the safety profile of levodopa in patients with Child B class cirrhosis is very similar to Child A. Grade 3 to 4 treatment-related adverse events only observed in about 6%. Objective response rate somewhat similar, 10%. Median duration response about 10 months. Disease control rate of 55%. So it looks like levodopa is, can be used. It's safe and similar efficacy in patients with mildly decompensated cirrhosis. So what else is in the horizon? I'd like to select a few pivotal trials with combination therapy that are currently ongoing. Some data, preliminary data has already been presented in abstracts. So there are two broad categories. First, a combination of immune checkpoint inhibitor plus an anti-angiogenic agent. So the examples include the LEAP-2 trial comparing lenvatinib with pembrolizumab versus lenvatinib. And then the COSMIC 312 trial comparing cabozantinib with atezolizumab versus sorafenib. And then there are also a few combination trials with two immune checkpoint inhibitors, the Checkmate 9DW, which is Nivo plus Ipi versus either sorafenib or lenvatinib. And then durvalumab which is an anti-PD-L1, and also tremelimumab, which is an anti-CTLA4 versus sorafenib in the Himalayan trial. So some very exciting studies are ongoing. There are also a number of large clinical trials looking at adjuvant therapy with these drugs after either resection, ablation, or chemoembolization, which I don't have time to go over.
Professor Yao, we're running out of time. If you could please
oh, yes,
now.
yes. So sorry. So what else is in the horizon? So basically, just to summarize, this is the algorithm for systemic therapy. So, this has changed. Atezobev has outperformed. Sorafenib is now recommended as new first-line therapy. Until we have more data, off-label use of multi-kinase or VEGF inhibitors may be appropriate as second-line therapy. Sorafenib or lemetinib are alternative first-line treatments in patients ineligible for atezobev, and there are very well established second-line therapies as shown here. So finally, as we see more choices in systemic therapy, we need to use these drugs with good understanding of potential toxicities and serious adverse effects. The common ones include hand-foot syndrome, which you are well aware, diarrhea with all the TKI inhibitors, hypertension with atezobev in particular. And then, this is an area that we're seeing more and more, immunotherapy-induced hepatitis and even liver failure in some cases. So I want to thank you for the attention.
Thank you, Dr. Francis Yao, for a very nice talk about the recent advances in undetectable hepatocellular. Now, my duty to introduce the panelists to join with our these sessions. First, I introduce that is Professor Kin Mong Win from Myanmar, and he is a professor, Department of Hepatology, University Medicine 1. And the second, I invite to that is a panelist, Sutam Shu K, Professor Affiliation, National Academy of Medical Science from that will be this Nepal, and Professor Icha Ilmi is a professor, consultant gastroenterologist, University of Malaysia, and Kuala Lumpur, Malaysia. And finally, that will be I invite there will be Dr. Shyam Agarwal from USA, and from finally there will be my mentor, Dr. Sid Babu, is head of the department G in Krishna Institute of Medical Science. I take part in being as a panelist for the discussions.
Yeah, sorry about running late.
Yes, thank you, Dr. Narayan. I think we have had an excellent talk, and we have several important questions in the chat box. So to set the discussion rolling, a question that's also bothered me and which I think Dr. Ashish Kumar also wants to ask you is, what is the role of these new drugs in combination with various loco-regional therapies? Do we have data whether combining these with LRTs will have improved outcome?
Yeah. So as you're well aware that sorafenib data with resection and ablation in the STORM trial and also in the SPACE trial were very disappointing. So it's very exciting now. A number of these drugs are being studied in combination with either chemoembolization or with resection and ablation. I can mention a few. With resection or ablation, there is the Keynote 937 study on pembrolizumab, and then the Checkmate 9DX study for nivolumab, and then also the durvalumab and bevacizumab in the what we call EMERALD trial, and then atezobev is also being looked at. For TACE, there are a number ongoing, the EMERALD-1, sorry, with durvalumab and bevacizumab, and also nivo plus ipi in the LEAP study. So very exciting. So none of the studies are available even in preliminary data, but they are ongoing. So a number of these combination therapies can be used after resection ablation is adjuvant therapy or aftertaste to see if that would actually improve the overall survival after these non-curative treatments.
Professor Yo, with all the development of the newer drugs, very effective, less side effects, how would you consider the role of sorafenib at this point of time? And what is in your clinical practice, do you still use sorafenib?
Yeah, so we have shifted. We have used sorafenib as first-line therapy for years, but now we are switching to atazobeth. There's definitely still some, a significant role of sorafenib, because I think that, of course we don't have, a really good data yet, but you can go from one spectrum, the immune checkpoint, to TKI or vice versa. So I still think there's a role for sorafenib. Particularly there are patients who failed combination or immune checkpoint therapy. There's still a potential role. This will be off-label use, but you're right. So we have used sorafenib for a long time, but now the paradigm seems to have shifted. We are now using atazobeth because the difference in terms of survival and also the objective response rate is clearly superior with atazobeth.
Thank you.
So in continuation with this, I think we have an interesting question in the chat box again, that can be used, is there a role for biomarkers to select patients, whether we should prefer sorafenib directly or so first line, or we should straight away go with the newer combinations like atazobeth?
That's an outstanding question. So I think that the way of the future is really use biomarker to guide our therapies. But there's been a lot of proposed mechanisms to say which ones we should use, immune checkpoint, which ones we should use sorafenib. We haven't seen enough data to make that recommendation yet. But biomarker guided therapeutic approach is really the way to go. I totally agree with that.
Can I?
Setu, please go ahead.
Yeah, thank you. Professor Yao, it's a wonderful talk. And I would refer to your third slide, which actually refers to the ESL position paper, which is yet to come on print, has in fact has published all the data available right from SHARP to the IMBRAVE study. But I thought you will make one very important point is what is the impact of treating B and C, even these in advanced tumors? Do we continue to manage them with B and C therapy?
Sorry. You're talking about the BCLC B and C?
No. I'm talking about Hep B and Hep C.
Oh, Hep B and Hep C. Very. Yeah, I don't know the answer to that. Like based on the experience with sorafenib, the SHARP trial and the Asian trial show very similar results. So I don't think that I can point a finger that hepatitis B patients are different. And then the combination trial, the Orient 32 is almost exclusively hepatitis B. We can't really extrapolate one study to the other population, but my sense is that hepatitis B may not be a unique situation, that the response rate should be similar. So I don't think that etiology of liver disease play a huge role in terms of response to these therapies.
Professor Yo, you have a lot of combinations with all the similar efficacies. So in the real world experience, clinical practice, what do you choose? What combination you choose, or you have given the patient, explain to the patient and give the patient to choose, or you yourself, you choose? Who chooses?
Yeah, so we have a lot of choices. You're absolutely right. We have a lot of choices, but before atazobeth came out, I still use sorafenib. There are a few patients, who, may, like say, okay, should I use nivolumab, because the data looks okay, and then, nivolumab was quite, quite impressive initially, not in terms of the overall objective response rate, but the ones who responded seemed to be very durable. Even the 15% who responded seemed to be very durable. So I have in selected patients start with nivolumab as opposed to sorafenib in the past. But now I think that the path is a little bit clearer. Atezo-bev based on objective response, based on survival, outcomes really superior. So we're shifting to atezo-bev as a first-line therapy. What we don't have is the unmet need is what to do second line after you chose the first. And then what's really the real data beyond, like the first line therapy, so it's simple. If you use sorafenib, they're very, very good data that regorafenib is really a good choice. But now we have more options. Should we go to immune therapy instead of regorafenib? So that's a difficult question because we don't have all the data. But my sense is that I would probably, for those who fail regorafenib, I would go straight to atezo-bev.
Thank you. Can I ask the other panelists for their comments? Professor Sudhanshu, Professor Hilmi, Professor Shyam Agarwal, please offer us your comments or views on the excellent talk we have just heard.
Professor Yao, thank you. I'm Ida Hilmi. Thank you for an excellent talk. I have to say I'm not, I do manage HCC, but I'm not, your diehard hepatologist. I wanted to know your opinion about the kinky criteria on intermediate, BCLCs and whether or not we should be, what's your opinion about TACE versus these therapies since we have so many available?
Yeah, that's a very important question. I consider myself to be a little bit more of a purist because unless you have, level 1 evidence, I would still go with what, for instance, the radioembolization, a lot of people are high on, but you really don't have, strong level 1 evidence that radioembolization is better than chemoembolization. And then we see, radioembolization versus sorafenib, and there's no significant benefit. So I would be a little bit more careful in terms of, like going with the standard of care, the intermediate stage. I think that Y90 radioembolization or chemoembolization is the way to go. Now, shifting those, systemic therapy to that group, I think is reasonable if they, they are, like not great candidates for local regional therapy. So the stage migration concept, I think, is totally acceptable. But right now, I would not shift the standard in terms of what is considered first line. Did I, not sure if I answered that question.
Can I make a comment?
Nice talk.
Yes, sir. Yes, Professor Agarwal, good to hear you. Please go ahead.
I think I made my comment in the chat box. So, in order for us to reject a patient for atezo and bev, so there should be a contraindication, such as bleeding within 6 months and therefore impending bleed by looking for upper GI endoscopy, or a patient who has a contraindication for bevacizumab, for example, a cardiac ailment or a thromboembolic disease, or a contraindication for atezolizumab, for example, an autoimmune disorder. So other than that, of course, this is a financial toxicity as well because these are expensive drugs. So the current treatment revolves around atezo-bev unless there is a contraindication. So patients who cannot afford, well, sure, they are to go on a drug like sorafenib or lenvatinib.
That's a very good point.
So there's another quick question for you.
Yeah.
Do you need a liver biopsy? What is the role of liver biopsy and PD-1 staining or assay? Does it have any role in making a choice of therapy?
I don't know the answer to that. I haven't really used it in my practice, so I need to look into that a little bit more. But that's an excellent question.
Can I ask a question, Dr. Vivek?
Please, yes, Professor Arora, please go ahead.
Yeah, Professor Naruddin, why is it that most of our patients do have an advanced intermediate disease requiring both LRTs, the concomitant therapy? You see, LRTs will not completely at molecular level will extirpate the tumor. Still, there will be impending and leftover molecular mechanisms which will lead to recurrence. Why is it that none of these immunotherapies or MTKs, they are known to have increased survival after LRT? That means, are we missing the target of molecular mechanism of HCC completely? Are we off the track?
You know, I think that you made an excellent point. I think that we really don't, you know, understand the mechanism well enough to really guide our decisions about what to do. So I think this is a very major area of further investigation, no question about it. We're still like in the infancy in terms of using these treatments.
Professor Sudhanshu, you have any comments? Professor Narayan Swami?
Yeah. Okay, nice talk, Professor Yao. I just wanted to ask, what would be the role of SBRT after the failure of chemotherapy or in combination with chemotherapy?
Yeah, so I know that SBRT is a very popular treatment, you know, in many centers in the US and in Asia. You know, I just struggle with not seeing enough data about SBRT, you know, particularly there's no level 1 evidence. So I know that the anecdotal experience is very favorable. We have used quite a bit of SBRT in selected cases, mostly because they failed chemoembolization, whether they are being bridged to transplant or as monotherapy. But there's really, there's really a lack of good evidence suggesting that you can use combination or you can use it alone. I think that off-label, patients who fail local regional therapy, other ones, is a very reasonable treatment to offer them. But I would not go beyond like combining it with other, with systemic therapy, for instance. But I would use it as a kind of rescue therapy in some patients who still have enough functional reserve or still has relatively good liver function who failed the other local regional therapies.
Thank you.
Professor Yao, I think you spoke to us briefly in the Checkmate 040 about using the combinations nivolumab for Child's B. Other than that, or in more advanced diseases, are there any other molecules we can look forward to that might be effective? Because many of us are cirrhotic patients.
Yeah, this is an unmet need. That's a very good question. This is an unmet need. I'm looking very hard for any data, but so far none. So right now, the only two treatments that we can consider are nivolumab and also sorafenib. I think that sorafenib is still relatively safe in very mildly decompensated patients, but beyond that, we just don't have any information. But I think that as we, in clinical practice, there may be real practice data. This is how we learn about sorafenib. There may be real clinical practice data to say that some of the other agents may be okay, but all the studies are purely Child's A, no decompensated liver disease. So we are very limited in the decompensated group.
Right. Thank you. Anything specifically that we can look forward to in post-liver transplant recurrences of HCC? Any data or specifically looking at this, which is an important subgroup of patients?
Yeah, this is an area that I'm really interested in. So we developed this new staging criteria called RETREAT to really identify the ones after liver transplant who had very high risk of tumor recurrence. So we definitely need adjuvant therapy. We are interested in, in some immune checkpoint studies, but the risk is really there. We only have anecdotal experience that, there are some rejection episodes with liver transplantation. So it makes it very difficult for us to design anything because of worry about rejection, to use preemptively after liver transplant to prevent recurrence, even if they're very high risk. So right now, the standard of care is really not to do it preemptively, but to treat after they recur, which I think is suboptimal. So just because these are the really complex immune interactions that you worry about rejection in these patients, that I think is going to make things very difficult for us to develop anything.
Okay. Well, I think we have had an excellent session. Panelists, anything else you would like to ask or any other comments before I think we
Yeah, I'll make a quick comment. I think if you look at progression-free survival PFS versus side effects, I think the benefit depends on combo therapy in future when you talk about progression-free survival. Maybe one drug may not work or some kind of sequential therapy which we use. We still have liking to sorafenib because that was the experience years back and continue to use it. But I think our experience with modern drugs is still not very exciting, nor we look at child criteria as the real indication, even in unresectable. I don't know the comment about that.
Well, I think that's an excellent point. There's data that sequential therapy with sorafenib followed by regorafenib actually worked. So you don't have to wait for one drug to fail. But how do we design clinical studies like that is challenging. So I definitely think there is a role for sequential therapy in our approach to HCC. Maybe some combination sequentially is actually going to work better than waiting for one to fail and then try something else. So that's an excellent point.
Any comment, Dr. Sham? I thought I saw your hand go up.
Just want to reiterate what Dr. Yao said. The checkpoint inhibitors like atezolizumab are contraindicated in patients who have recurrence following transplant because of the risk of rejection. So you must never think of using checkpoint inhibitors. Although I think there are anecdotal reports, but I think they are actually contraindicated. So I think that's the point.
Yeah, we have not used it, because of that reason. So, not off-label. So.
Well, and unless there are any other pressing comments, I think I'd like to thank Professor Yao for an excellent presentation and the very lucid and a clear question-answer session. And to thank all the panelists for perceptive questions and overall an extremely educative and useful session on advanced hepatocellular carcinoma. Thank you, Professor Yao. I'd like to hand back to the to the moderators of the meeting.
Thank you.
Thank you, Dr. Saraswat and Dr. Narayan for this session. Now we move on to the next session, that is session 4. The topic is what's new in the diagnosis and management of hepatitis B. And for this, I would like to invite to moderate Dr. R.K. Dhiman, who's the present director of Sanjay Gandhi Postgraduate Institute in Lucknow, and Dr. P.N. Rao, who's the current INSL president as well as director and chief of hepatology at Asia Institute of Gastroenterology, Hyderabad. So Dr. Dhiman and Dr. Rao, over to you.
Thank you, Dr. Ashish, and thank you, Dr. Anil Arora also for this organizing this wonderful conference. So far, all the sessions that I have heard, they are very useful and with a very good discussion also. And now coming to this session, Professor Shiv Sareen is well known world over. I think he does not need any introduction, but I have to talk about him in short. Professor Sareen is the senior professor hepatology and the director of the Institute of the Liver Biliary Sciences, that is ILBS, in New Delhi. He was instrumental in setting up the Institute of the Liver and the Biliary Sciences under the auspices of the government of the Delhi. He is also the director, WHO Collaborative Center on the Chronic Liver Disease and the Viral Hepatitis at ILBS. He serves as the adjunct faculty molecular medicine at JNU due to his deep interest and the contributions to the translational sciences. He is credited with several new treatment protocols for the liver diseases, including varicose bleeding, liver degeneration, hepatitis B, and acute on chronic liver failure. He has more than 670 publications to his credit, edited 13 books on the liver diseases, and contributed more than 87 chapters in various medical textbooks. He has helped develop 19 major guidelines so far. So may I now request Professor Sareen to take over and deliver the talk. Dr. Sareen, please.
Thank you, Dr. Deeman, and thanks, Dr. Anil and the team. It was a pleasure. Can you see my slides, please?
Yes, we see your slide also.
I bring greetings from ILBS. The topic, hepatitis B, everyone knows everything. So it was difficult, but I made some choices. Tests to follow if DNA is negative on treatment. So going back to the hepatocyte, this is sinusoid, blood is flowing.
Your
Hair,
slides are not moving, sir.
slides are not moving? Oops.
Yes, it's okay now.
Sir, make it full screen, sir.
Full screen, please.
Is it moving now?
No.
Make it full screen, please.
It is full screen.
It's moving now, yes.
Is it moving?
Next, karo.
No?
No.
I think you will unshare and then share again. Stop sharing and come back again.
Is it moving now?
We can see the slide saying outline.
Now?
No.
No?
Yes.
All right.
Yes.
I will stop share one more time and I will close this and open it again.
Stop sharing and re-log in, then we'll be able to.
Is it okay now? Can you see the slides?
No.
No. My apologies for this. I had opened it and so.
Dr. Sareen, first is the share screen. When you see the screen, then again click on the share. Yes, it has come.
It has come now?
Yes, it is there. Now make it a full. It is full screen. Slideshow, please. Yes.
Now it's okay.
Yeah. It
Sorry
is
for taking time. I will cover up fast. First question. If DNA is negative, what do you do? So let's go to the virus. Here is the nucleus, the hepatocyte. When you have the virus coming in, you have CCC DNA, the large and small, and all these 5 RNAs. Now just see that pre-genomic RNA makes directly HBsAg, which has the DNA. But also you have several pre-core and core proteins which will go out, several surface antigen particles which will go out. And remember, this is very vital, HBsAg subviral particles. These subviral particles move into the cytoplasm. These are very important new areas. We'll come to it in a while. Now you have a patient who is E positive, immune tolerant kind. You will see the HBV DNA, quantitative HBsAg, HBV RNA, all of them and correlated antigen are high. As they go down, everything goes down. But remember, quantitative HBsAg is very rarely goes down, even in what you call as chronic carrier and now called as E minus chronic B. Even after seroclearance, remember that seroclearance is not seroconversion. You still have all these viral particles present. Hence, HBV is a very difficult disease, and we need to use all these 4 markers. Let's look at On therapy, at baseline, you have a high DNA, you have a high RNA, and you have a high correlated antigen. You have given therapy at 48 weeks, there is no DNA. 96 weeks, no DNA. But you still have a lot of HBV, RNA, and correlated antigen. It's not easy to do them. So what should we do? We need to go back to simple quantitative HbA1c. When there is no DNA, still do quantitative HbA1c. So first new message, every patient who is DNA negative is followed by quantitative HbA1c. Second part is the role of fibro. LSM with normal ALT and abnormal ALT. Many times when the ALT is high, we forget it. We say, oh, his ALT is 85. The the fibroscan will not be normal. And this is the European guidelines. About 12, we think it is stage 4 or cirrhosis. But even if the ALT is high, but less than 5 times, take up to 17.5. And for a normal, stage 2 fibrosis, where you think liver biopsy is needed, 6 to 9 and 9.4. So I would always recommend that even if ALT is high, do LSM. Second, stopping rules in E minus chronic B. It's a hot topic for almost 12 years now. I'll just show you a case, 42 male, baseline. ALT was high, E minus, DNA 10 log raised to 5, fibro 9.6 by F3. This is a real case. He received NE4 for 7 years, and now for 4 years, this guy is DNA negative, ALT is 41, fibro, you can see, has come down. Question is, can you stop NE4 and what are the risks? And which test do you need? Well, a repeat biopsy, probably. ALT, probably not. Quantitative HbA1c, yes. And let's look at some of this. So this is the new guideline which just got published in Hep International, that if you have a patient who is undergoing nuke therapy and his HbA1c is less than 100, you can be comfortable. If it is 3000 or so, you have to continue. So first message is quantitative HbA1c will determine. Of course, if you want to add on PEG and others, you can continue trying this. But for me, this is important. You only stop if HbA1c is less than 100. There are some very interesting new data from this. So these are the old guidelines. Relapse is DNA more than 2000 after stopping nukes. Clinical relapse is viral plus ALT 2 times upper limit of normal. Now, this is Yunfin's exciting new concept. You have a patient who has hepatitis B and you are stopping nukes. After stopping nukes in a E minus, the question is this a host-dominated flare or a virus-dominated flare? Now look at this carefully. Now this is a flare which has occurred in 4 weeks' time. And here you will see the DNA has gone up like that. So first thing, virus-dominated flare comes early. Host-dominated flare will come many, many months ago. Actually, it should be 6 months or so. So 6 weeks, 6 months. You have to differentiate a host versus virus dominating flare. How do you monitor after stopping E minus and nukes? So it will show you that if there is a clinical relapse, means ALT high, DNA high. In that particular case, you will start monitoring these patients. And how do you monitor them? This is the time in weeks. You will keep on monitoring every month, month and a half, or 3 months or so. If ALT is more than 2 times, if it is more than 5 times, weekly to bi-weekly, including bilirubin and iron. And what will you look for? Success of stopping means your quantitative HbA1c goes down. You will follow for 12 months. You will see that your patient's host-dominated flare clears the virus, not viral-dominated flare. So which patient has low risk of relapse? So if you want to stop, the guy wants to stop, quant HbA1c less than 100. Consolidation period minimum 3 to 4 years means there is DNA is negative, ALT is normal. Lower DNA at beginning and no pre-core, sorry for error, or BCP mutations. Our patient sustained undetectable DNA on nukes, advanced fibrosis, can stop nukes, and quant HbA1c will guide us. Note down please your questions and we'll be there to answer with panelists. Third, people very often ask, sir, spontaneous HbA1c clearance is better than nukes. All right. So this is the interesting paper by Choi, which shows you that spontaneous HbA1c clearance will HCC be more or nuke-induced HbA1c clearance. Just to conclude, there is no difference. HbA1c, if you have a seroclearance in that, then there is no difference whether it is HbA1c due to nukes or it is due to spontaneous clearance. This is a very exciting paper by Anna, just shown few weeks ago. You have an analytical sample and you have baseline cirrhosis versus no baseline cirrhosis. And here you will see that development of HCC is almost 1 in 7, while in others it is much less. So baseline cirrhosis remains a major challenge. And most of patients coming to us do have advanced fibrosis or cirrhosis. Now, these are two very important and often neglected risk of HCC on therapy. There are two types of factors, virus or non-virus related factors. Geno C, not seen here, but just recently, yesterday I read genotype A also has extremely high hazard ratio. Persistent ALT above 45, not 80. See that 3.8 times. DNA, yes, high risk. E positive, yes. But very importantly, BCP mutation, which is the mutation which interferon induces. Normally, it is not induced. So if you have this mutation, you give interferon, it will be far superior than giving nukes. And of course, as I said, cirrhosis. This is to show you obese HBV cirrhosis has a higher risk of liver cancer, metabolic syndrome, or obesity. Drugs. Very interestingly, statins decrease the risk. Aspirin. I love to give aspirin, but difficult in cirrhosis. Metformin, yes. Thiazolidine drugs. Insulin increases. So please try to convert all your patients, diabetics, on insulin to other kinds of drugs, not even sulfonyl, metformin, and other new drugs. Now, this was pre-therapy. Now, let us see, one more point in treatment naive. Now, what is the role of fibrosis? I'll come, and then on antivirals. We have several scores, REACH B, PAGE B. I'll come to it in a minute, but let's see about fibrosis. So this study from Korea compared to low liver fibrosis, LSM, you will see that those who have about 23, the chance of developing cirrhosis or cancers is several fold high, almost 20 times higher. So if you have a Hep B with a high LSM, be careful. Hepatitis C, it is 25, B is 23. This data subsequently confirms it. If the LSM is 21 to 30, then the risk in 3 or 5 years is 10% to 12% or so. So remember, stiffness matters. Now, this is to show you that if the stiffness is above 13, even then the risk is much higher. So I think we have to remember all these data to say that stiffness, especially above 13 and more so above 20, is worrisome. Now let's look at the risk scores when the person is already on nuke therapy. And this is to show you that 3-year risk is 3%, 6%, and 10%. 10-year, 10% risk of HCC. Now, which of these scores are better? So the REACH B score is all these scores. Firstly, if they are low, they are predictive of no HCC. But if they are high, sensitivity and specificity is 70 to 80% or so. Most popular now are PAGE B and M-REACH B. And these scores are simple: age, sex, ALT, E antigen, or LSM. This has LSM. While PAGE B is so simple: platelet, age, gender, and yes, hepatitis B. There are several other new scores. I don't have the time, but this CAMD score, which has just come, uses no hepatitis B markers, but uses cirrhosis, age, male, and diabetes. What I want to just emphasize is we often forget. So just remember, on therapy, please look for HCC scores on your card. Now, the incidence of HCC according to PAGE B, platelet, age, gender in Hep B. And here you can see that if the score is more than 18, you have a high risk of HCC. You can use any score, they are pretty close to each other. Now, how do you also assess HCC on therapy? We generally use AFP and rising AFP. I have not shown you the very new guidelines that AFP above 5 is bad enough. All our centers are using 8 or 10, but new data says AFP 5. If it is 3 to 6, start worrying. Combination of 2 above 100 PIVCA, above 5 AFP, and you have a very high sensitivity and specificity. So don't use AFP alone, use in combination also. There has been huge debate by the companies whether tenofovir or entecavir. The bottom line is both are equal. Please raise your questions for this. The last part includes new therapies. So new therapies are new potent nucleoside analogs. They are coming in. We also have several drugs which are CCC DNA inhibitors and immune modulators. I will not discuss any of these. I will only discuss later after giving you the concept of inhibiting HbA-CG. So here, entry inhibitors. You have inhibitors of CCC DNA. You have polymerase inhibitors, which we use every day, inhibitors of nucleocapsid assembly, and you have inhibitors of HbA-CG release or HbA-CG inside. Of course, you have immune modulators. I will discuss only this. To me, they appear to be the most exciting new drugs. So let me go back to one more time about the subviral particles and HbA-CG. When the body makes, the liver makes one HBV DNA, full virus, 9,999 hollow HbA-CG are released. And this is the amount produced inside the hepatocyte. And Dr. Mamoon, who is one of our panels in there, he was amongst the first to have initiated the NAP-related work. What are NAPs? NAPs bind viral proteins. These are amphipathic helical structures, and they have some hydrophobic interactions. And this is what it is like. Here is a hepatocyte. There is a CCC DNA in the nucleus. It makes subviral, huge amount of HbA-CG particles which are being released, and some full HBV DNA particles. Now, all these particles were circulating here present in the cytoplasm. See, all of them are released. When you give drugs like NAPS, Rep2139 or other new drugs, there is an inhibition by NAPS of the subviral particle production, assembly, and if they are produced, they will all be mopped up. So what you see is if you have initially high HBsAg levels, within a period of 20 to 24 weeks, the HBsAg will start declining and so will be HBV RNA and DNA. What is the advantage? When you have HBsAg, it is a decoy. All your CD8 T cells will be fighting with them. Very few are left to fight with them. If you remove all this HBsAg, your CD8s will fight with them. So the advantage is you remove HBsAg and you make your CD8s work on this. So if you have long-term studies, there is a huge advantage. And this is what has been shown in this beautiful gastro paper, that when you give a tenifo, PEG interferon and NAPS, HBsAg loss is high, seroconversion is high, and there is a transaminase flare. And this flare is because CD8s are killing the cells. And finally, you achieve functional care. So I think tomorrow's new drugs would include, some of these patients had ALT levels going to 1400. If you see that paper. So it is converting a chronic B into an acute hepatitis B, and that is the way I think we can go forward. So this is my last slide. What we do, tests, if the DNA is negative, is quantitative HBsAg, follow it. If 0.5 log reduction in 1 year, it is a great achievement. Core-related antigen can be another test available now. Stopping rules in E minus, HBsAg is less than 100. Whether it is spontaneous or nuke-induced clearance, they are equal. The risk of HCC on therapy, page B, or any other thing. Use statins, antiplatelets, stop smoking. Ask the patient to stop smoking to prevent all HCCs. And Rep2139 and immune checkpoint inhibitors can be the new therapies. I think our journey has just begun and we have miles to go, like hepatitis C, to get the appropriate drugs. Thank you for your attention.
Many thanks, Professor Sareen. And then you always make the things simple, complex things very simple. That is your major contribution. And it's my privilege to, especially the two things which, you brought back the HBsAg quantification, which we have been doing some initial changes, and then somewhere along the line, we lost the loop. And also emphasizing that the small increases in HCC is very important in the hepatocellular carcinoma detection in hepatitis B, which I call it as a rogue virus. It has fooled many of us at many times. And with this, let me introduce the panelist here, and Dr. Sheikh SMF Akbar, and then who has been a frequent contribution of his basic research in hepatitis B. He is from the AIM University Graduate School in Japan. And Dr. Mamoon Al-Mehtab Shopnil, that is just now Dr. Shiv Sareen mentioned to him. He is from Bangabandhu Sheikh Mujib Medical University, and then he's been associated with our journal and also in the SAZIL. Dr. Ali Nazim, who is a consultant in internal medicine, Indira Gandhi Memorial Hospital, Maldives. Dr. Kaushal Madan, who is the immediate past Secretary General of INASL from Max Hospital, Saket, New Delhi. And Dr. Pankaj Puri from Fortis Escort Hospital. With this, I would just hand over to Professor Dhiman, to continue, please. Dr. Dhiman, please.
Thank you, Dr. Rao. First of all, I would appreciate the outstanding talk, and as you rightly said, complicated things were made very simple also. Now we will be discussing it with the panelists also. The first question that I would like to uh, ask is from the Mamun Al Mahatab. Because he is working in the NAP. So I would like to have his comments on it.
Thank you, Professor Dhiman. It's a pleasure and honor actually to be a panelist in a session where Professor Sarin is speaking. I'm grateful to him for mentioning my name in his talk. We have had the initial experience with NAP. Actually, the clinical trials in humans began in Bangladesh with me as the clinical PI. And we did work with NAP for a long time, trying to combine LAP with the nukes and then pegylated interferon, different combinations. My experience is that it works wonderfully. HbSAg becomes negative as early as 8 weeks. And these are actually all treatment-naive patients with very high HbSAg levels that we treated. One problem with these drugs that I have seen in the later stages is that this response in many cases were not sustained on long-term follow-up. Which however was not published. HbSAg did come back, anti-HbS levels fall. And after following up many of those patients who were on the initial trial, we did notice that their liver disease eventually progressed. So these are the challenges that we have seen with these patients. And one more thing that we experienced that may be a challenge with NAPs in our part of the world is heavy metal poisoning. For the first time, we saw that these patients had difficulty in swallowing, and after much investigation, much exploration, we found that they had high content of heavy metals in their body. And then when we looked into the cause, we then discovered, following a newspaper lead, that the areas they were coming from around Dhaka city, for cultivation, they were using high doses of insecticides. And there was high content of heavy metal in those fields where the crops were coming from. So there are certain issues, as Professor Sarin was saying, that Hep B, the journey has just begun. It's a long way to go. And we hepatologists actually have to, expand our horizon. You see, following up these NAPS patients, a newspaper lead, we investigated and found that heavy metal poisoning was the cause. And I know that when they are now continuing the trials in Europe, in South Europe, Eastern Europe, they are looking into heavy metal levels. And there is a contraindication maybe for these patients. So there are many things, but I can tell you that these are very promising drugs. Dr. Akbar is also here. We have also worked with another immune modulator with him. That is also a wonderful agent. But I can only say that whatever we are treating with today, maybe our residents or their residents, when they become professors, they will look at us and say that they were like today we think of lamivudine. They will think looking at us and think that we were playing with lamivudine. The drug, the spectrum of HBV treatment will be entirely transformed in the days to come. That is for sure. Thank you very much.
Dr. Mamun, you have told about the heavy metal. Any heavy metal in particular you want to say? Or
they had high content of lead in their body. And actually, I was also one of the volunteers because we are very surprised, to see. And actually, I also got investigated and found that even in my body, the heavy metal content is high. And that is a very common thing in citizens of Dhaka city and neighboring areas. Now we know that.
Dr. Sarin, would you like to add some comments to the Dr. Mamun's comment?
Well, I think these were initial studies, but I had the privilege of having the direct talk with some of the original investigators now. Their only concern is that 2139 and the newer version of that, it's very good. The gastro paper has shown. I think in general, these are conceptually very good drugs, but large trials are required. To me, removal of HbSAg, there were days when you would do plasmapheresis or something, or give anti-HbS to kind of absorb HbSAg. So I think removal of HbSAg is the fundamental approach today, or its production can be decreased. So okay. I think, yeah.
Thank you so much. So now I come back to the, Dr. Sheikh Mohammed Fazle Akbar. Dr. Akbar, you are here?
Yeah, I'm here.
Okay. How are you? It's fine.
Fine, going on.
I would like to have your comments, and particularly I would like to have the comments on the HB core antigen actually. But what is relation toward the cccDNA or its implications as far as the management of the hepatitis B is concerned, or maybe the occurrence or the recurrence of the hepatocellular carcinoma also. So this is the one, yeah, please go ahead.
Okay, the question, the problem is that we all know that cccDNA is a problem. But the thing is this, we found many people with the cccDNA without any kinds of liver damage. So whatever the things, whether HBs antigen, HBV DNA or other thing are there, important marker, the ultimate problem is whether it is the viral mediated host responses or the host mediated immune responses. The damage of the liver cell is the most important thing. So my query about the presentations of Professor Sareen is this: the new and the evolving drug, which is the major problem of this time, is to find out the 90% persons who does not know, and we need a finite treatment. So is there any option that a finite treatment is coming out of this new evolving therapy? We all know the anti-cccDNA, anti-RNA, and many drugs, anti-inhibitor, and clinical trials has been done with a lot of the things. So what is the conceptions of Professor Sareen about the finite therapy, which can be used in the 90% people who have not found that they are infected, and that is required for the elimination of hepatitis by 2030. So if there is an idea, Professor Sareen, please.
I would choose my patient for finite therapy if his ALT is 2 times upper limit normal and his HbA1c quant is less than 1500. I will treat others, and his Geno A means he's E positive. But if he's E minus or Geno D, then generally TAF or tenofovir or Anteca would be used. Now there is a huge excitement globally on treat all. So I think like HIV, we treat all. For hepatitis B, treat all. Initial apprehensions that the TAF or Anteca on long periods can have side effects have generally gone. So people would like to treat all. I saw in chat box 1 or 2 questions, I think Praveen or others, they said that if there is a DNA which is less than 200, 2000 and normal ALT, will you treat? I would say no, unless the LSM is above 8. But for others, on protocol therapy, one can try. New drugs. Yes, please.
One small question. This presentation is also about the diagnosis. So actually, we need to have the 90% people who are undiagnosed. So in Africa and in some area, the new diagnostic different types of kits and spot diagnosis has. So will you give some idea about these things?
Yes, it's a very good question. Many places in Africa, people are not willing to give blood and others, so saliva can be tested, can be put on to a immunoblot or a blotting paper, and can be sent. Saliva will have just 2 logs less than in the blood DNA, so that can be used. Very nice. Thank you for reminding. And the other approach people are using today is that those who are going for vaccination for COVID, all of them are getting investigated for hepatitis B and C in some parts of the world. But you are an expert, you can add some new things.
Thank you. So we are working on that, the African spot age-based antigen diagnosis, which is very cheap, and we can have the same thing you told, we can have the blot, and then we can find out whether he is positive or not. Thank you very much.
Thank you, Akbar. Let me take one question from the chat box, and this is from the Praveen Sharma. Will you like to wait in patients with the advanced fibrosis or cirrhosis to differentiate between the viral versus the host predominant response? Dr. Sareen, please.
Not at all. I would not include anybody for stopping nukes if there is stage 3 or 4 fibrosis. Only F0, F1. If F0 somebody has started, or F1, no question of stopping nukes. and experimenting if it is F3 or F4 therapy. No.
Okay. There is another question in the chat box that is does horizontal versus the vertical transmissions makes difference in starting therapy in the patients with the detectable HBV with the normal LFT, and this is from the Dr. Pavan Hanshanel.
Yes. Very good question. And I know I am the odd man out. I do not believe today you see any horizontal transmission. I think everyone is mother-baby transmission. And therefore, if you have a patient who has Hep B, I would consider it as a perinatal or mother-baby transmission. Yes, if it is a horizontal transmission, that is through vaccination, blood transfusion, chemotherapy, I would think it is a reactivation of a hidden virus. Very, very rarely it will be chronic by blood transfusion. So all are generally mother-baby. And how do you diagnose? One more time, this was a paper by Sanjay Satpathy way back in 2004. Patients, the children, their mothers were tested. 18% of the mothers were positive for HbA_CG, but about 70% were positive for anti-E, anti-core total, or anti-HbS. So we test all 4 markers in the mother or siblings.
Dr. Devan, can I ask a question, Dr. Sareen?
Yes, yes, please.
Dr. Sareen, you said that HbA_CG production is 10,000 more than the complete virion production after making a journey through the nucleus.
Yeah.
What you're doing with NAPS is just preventing the exit of the HbA_CG subviral particles. Wouldn't they be diverted to the complete virions? I'll give you a corollary. If you're using ACC inhibitors in NASH, you're having more of hypertriglyceridemia. So it is a side effect. Maybe by blocking the entry into outside the hepatocytes, you are diverting them to more virions.
Yeah, I think that is what we want, that let there be more virions. You have 10 raised to power 12 viral particle HBV DNA every day produced. So if you produce them, these, HbA_CG, where the CD8 T cells will come, they will kill them. So the amount of flares, every patient got flare. If you see that gastroenterology paper, the RAP is given and flare occurs. Flare means there is a T cell related injury. So you are right, you can increase lipids, but fundamentally you remove HbA_CG, whatever mechanism.
Okay, thank you, Dr. Sareen. So I now move to Dr. Ali Nazim. Is he here? Dr. Ali?
Yeah, yes, sir. Yeah.
Yeah.
Thank you so much. Thank you for the very, very enlightening lecture. I would like to state that we have a lot of patients who follow very regularly, or in recent times, unfortunately, due to the travel restrictions, they have been unable to follow up, mostly in hospitals in South India. So a lot of patients coming and meeting us now with interrupted treatment and different spectrums of hepatitis B markers and all this. So it's a kind of a challenge. I'm glad that some amount of answers have come out from this enlightening lecture from Professor Sareen. So I really thank sir for giving this guidance. So actually, we don't have a hepatologist or gastroenterologist as of now. So we physicians are treating right now. So we do have tenofovir and entecavir currently in the treatment protocol, but most of the advanced treatments we still refer to India for most of the treatments at the moment. So this is basically current scenario for us right now.
Thank you, Dr. Nazim. So I come back to the chat box once again. So we have the 2 questions for Dr. Sareen. One is, there should be voice for the treatment for all HbA_CG positive now onwards. I think it's a very provocative question. Yeah, please.
Yes, thank you, Dr. Nazim, for this. And I think the credit goes to Dr. Anil Arora, who every year creates a huge excitement into topics. And what you are saying is true for many of our patients for hepatitis B who have stopped therapy and are coming with flares, which is a correct thing. And you can count on all of us, they will be there. Coming to what Dr. Dhiman Sahab has asked is about whether everyone should be treated. I have told you my opinion. It should be only is if all of us agree on that. I think there is no scope of letting the virus go and letting it be transmitted. ALT is a very poor marker and fibroscan is very crude. Presence of virus should not be permitted in a human being.
Okay, thank you, Dr. Sareen. I think the association with the metabolic the syndrome and in a patient with the hepatitis B positivity, and there is another question: should LC patient, liver cirrhosis patient, be given statins irrespective of the lipid profile?
We don't have data, but all the data is retrospective. Those guys who were using statins had lower liver cancer. But as statin will help in any way, we cannot prospectively, unless studied, cannot say. But if somebody is on statin, you can continue, but the change to simvastatin, that is preferred. And obesity, certainly all efforts, because the risk is 2.5, 2.4 times of B plus obesity.
Thank you. Now I come to Dr. Kaushal Madan for his comments.
So good evening, everyone, and thanks to Dr. Sareen for a wonderful talk. I just wanted to him to highlight one point. He did mention about hepatitis B core antigen and HBV RNA. I know they are being done in ILBS, and he did mention that the assays are possibly difficult and expensive. So would he suggest that as a surrogate, HBsAg would be able to cover for all these markers as a surrogate for cccDNA, HBV RNA, and hepatitis B core related antigen?
I will simplify. HBsAg currently is done by dilution techniques. So if you have HBsAg, you have 1:100, but to do further by any of these two techniques, you keep diluting 1 in 10 raised to power 3, 4, 5. So there is a small chance of error. HBV RNA is, once standardized, is an excellent method of doing HBV. But if you cannot, the current HBsAg is a true reflection of cccDNA. So I generally use HBV DNA and quantitative HBsAg if the DNA is negative. But core-related antigen is a rapid test, but may not be as sensitive as quantitative HBsAg.
But there are the papers related to the core antigen test in relation to the cccDNA also and usefulness. Yeah,
it's quite good, as you say. Its efficacy, its sensitivity is very good, but you require a good team, and therefore, and it is a bit expensive, but it is going to come in maybe in a big way in next 6 months to 1 year. It will.
Okay, thank you. So lastly, I would coming to Dr. Pankaj Puri. Dr. Pankaj.
Thank you, sir. Thank you, sir. It's a wonderful talk by Dr. Sareen, and always some provocation. This treat all has always been a big debate, but we need more data to see whether this treat all will actually reflect into benefit by just eradicating the virus. And somebody who's say 10 years old or 15 years old, with everything being normal, are we going to treat? Yes, all guidelines, all recommendations, treating at younger age, and the recommendation of dropping it down 30 years or below are there. But should we treat somebody at the age of 10? That's another debate, and I think we'll take that forward. We watched very closely the evolution of therapy for hepatitis B, but really it has been nothing like the growth of hepatitis C. We've had the luxury of using lots of pegylated interferon while we were in the forces, because everything was free for the patients, but we found poor response. And I wonder how many of the panelists are actually now using pegylated interferon, considering its response rates.
briefly answer two parts before the panelists. One is, very often the debate used to go on gallstone, symptomatic, asymptomatic. Gradually, people are changing to get them out, and slowly. Similarly, HbSAg, you will see so many doctors who were positive, they never bothered about, and they just come with tumors. The only group which you will say, those who have got low DNA and no fibrosis, maybe you can leave. But if there is even slightest fibrosis which grows with obesity, diabetes, alcohol, why take a risk? And whether you will treat at 10, I don't know. I can't put my foot into that. But yes, adults, certainly. And PEG interferon is still, I use it. As I told you, anything above 80, ALT, E positive, and who needs treatment.
I totally agree with Dr. Sareen. There is lots of data that has come from his own center also, which including biopsies also published in the gastroenterology as well as in the hepatology journals also. That favors that most of these patients require the treatment also. As rightly pointed out, there are other cofactors also that makes it very important that these patients should be treated. But I think as rightly said, treat to or not to treat, it would take some time before we finally decide that all these patients should be treated. Finally, I'll request Dr. Rao to make comments. My co-chair.
Nothing. I think the time is up. We are going far behind the time. I think it's been a wonderful discussion. And then, as always expected from Dr. Sareen, as I already told you that, straight answers and always makes it simple, and then always brings some new things to his talks. And thank you very much.
Thank you, everyone. Thank you, Dr. Sareen, for the wonderful talk and the discussion thereafter also. And I also thank all the panelists also and my co-moderator, Professor P.N. Rao. Thank you very much. Now we close the session and over to Dr. Ashish.
Thank you, Dr. Dhiman. Thank you, Dr. Rao, for moderating the session and this exciting discussion. Now we move on to the last session of the day, which is on newer therapies for severe alcoholic hepatitis. And for this, I would like to invite the moderators, Dr. Sandeep Sidhu and Dr. Dharmesh Kapoor. Dr. Sandeep Sidhu is a professor of gastroenterology at Dayanand Medical College, Ludhiana. And Dr. Dharmesh Kapoor is a consultant hepatologist at Yashoda Hospital, Hyderabad. So over to you, Dr. Sidhu and Dr. Dharmesh.
Good evening, everyone, and thanks to the organizers for this wonderful syllabus and for this opportunity to moderate this session with none other than Professor Ashwini Singhal, whom we consider to be one of our own. Dr. Ashwini Singhal will be talking to us about recent advances in the management of severe alcoholic hepatitis. Dr. Ashwini Singhal is an Associate Professor of Medicine, University of South Dakota, Sanford School of Medicine, Vermilion, South Dakota, USA, and transplant hepatologist and Chief of Clinical Research Affairs, Avera University Hospital and Transplant Institute, Sioux Falls, South Dakota, USA. We look forward to hearing an interesting talk from you, sir.
Thank you, Dharmesh and Anil, for this opportunity. So let me share the slides. Okay, can you see the slides, please?
Yes, we can. Yes. If you could go full screen, please.
Full screen. Okay. Well, thank you. And over the next 20 minutes, and none of these disclosures is related to the presentation. So we will talk about, I think, few minutes on recognizing that current treatment of alcoholic hepatitis, especially the severe kind, which is the focus today, is a suboptimal treatment we have today. And that makes the rationale for need of newer targets, and we'll go over some of the promising drugs which are there in the field. And finally, come back to the basic that the risk control and alcohol use disorder not only is important, but is a pathology in itself in these patients. So they should have a kind of multidisciplinary approach in managing these advanced liver disease patients. So I think all of you are aware of the current treatment algorithm of alcoholic hepatitis. And if you focus on the bottom part of the slide, you can see that severe alcoholic hepatitis, which is defined by a MELD score of more than 20, more and more than a discriminant function-based stratification in the clinical medicine and clinical hepatology today. The treatments are very limited, is either corticosteroids in eligible patients and or liver transplant early on in eligible patients. So the word eligible applicable to only the two therapies available today, you can make out the treatment is not very optimal for everybody in this field. And one of the areas in alcoholic hepatitis you can see on the bottom left is what is the moderate alcoholic hepatitis, a MELD score of less than 20. And currently we don't have any specific pharmacologic treatment. We generally support them and maybe nutrition and just supportive therapy for liver disease complications. And this is important because moderate alcoholic hepatitis over a short-term period of about 1 month still has about close to 10% mortality, which is significant for any disease. So other things which make the current treatment of corticosteroids as suboptimal treatment, not only eligibility is not by everybody, but also the response is only half of the time in those who are eligible for treatment. And then even those who respond, the treatment benefit is, as far as the patient survival is concerned, is limited to a month. And beyond that, it is not any beneficial effect of corticosteroids. So clearly a very, very suboptimal treatment. So the second treatment, which is raising enthusiasm in the last decade or so, which is early liver transplant. This is a meta-analysis. You can see about 17-fold improved survival in those who are eligible and receive early liver transplant for severe alcoholic hepatitis compared to who are not eligible for this therapy, with an acceptable risk of harmful use of alcohol over a 2-year period, about 14%. But I think the more important, I'm not going to talk much about liver transplant. The focus will be more on pharmacologic therapies in the field of severe alcoholic hepatitis. So before we talk about the phase 3 or phase 2 studies for severe or moderate alcoholic hepatitis, I put this slide on just to recapitulate the pathophysiology of alcoholic hepatitis as basis for the newer drugs or newer targets in this field. So apart from the hepatocyte injury through generation of reactive oxygen species through direct metabolism of alcohol in the hepatocyte and in the liver cells, there are some indirect effects. The predominant of one in my mind is the gut-liver axis, which I think plays a major role in alcohol-associated liver disease and alcoholic hepatitis. And that stimulates the macrophages through toll-like 4 receptors, chemokine and cytokine-mediated inflammatory response. And finally, these chemokines and inflammatory response through death of the cells, and they also cross-talk with the neutrophil recruitment, the hepatic stellate cells, which are activated, and also the liver sinusoidal epithelial or endothelial cells, which are activated, and that mediate fibrosis and portal hypertension through nitric oxide mediated mechanism. But more importantly is that patients developing hepatocyte, either death or apoptosis, release some of the DAMPs or danger associated patterns, which in addition to PAMs, which are mediated through the gut-liver axis, they perpetuate the inflammatory cycle and leading to further inflammation and oxidative stress. And to any liver injury comes the hepatoprotective effect through gut, through the hepatocyte and other cytokine-mediated regeneration capability of the liver, and the balance between this ongoing inflammation and regeneration decides the fate of a given episode of alcoholic hepatitis in a given patient. So as you can see, the three boxes become more important as the gut-liver axis, the inflammation, oxidative stress, and the regeneration, where you can put the newer drugs into various baskets. So starting with the gut-liver axis, and I think this is a very provocative study early on this year from BCU, where the fecal microbiome transplant was not only shown to be safe in patients with moderate alcoholic hepatitis and alcohol-associated liver disease, but also clearly showing improved alpha diversity of the gut microbiome, which was expected. And this improved alpha diversity was associated with decrease in inflammatory cytokines, especially interleukin-6 and lipopolysaccharide binding protein. And this translated into a very important change in the gut-brain axis, which is alcohol craving by the patients and also their psychologic profile. So clearly, for the first time, the fecal microbiome transplantation showed not only beneficial effect on the gut-liver axis, but also the gut-brain axis, which I think is important as a second pathology we will see during the presentation today. And this was another important study from San Diego group, where it was shown that not only there is abundance of E. coli and E. fecalis in patients with alcoholic hepatitis, but also the cytolysin, which is secreted by these organisms. Importantly, the bacteriophage treatment of this cytolysin-producing E. fecalis attenuated liver injury in the mice, and this was translated in some of the samples from the patients. And similar data has been shown on fungal colonies in the microbiome or the gut fungal microbiome, if I can call it, and the same data using the approach to kill the candidolysin-producing Candida albicans. So there are more and more approaches coming, but still at a very experimental stage in hitting the gut microbiome directly through fecal microbiome transplantation or through bacteriophage treatment. Now, moving on to attenuating some of the inflammation directly, and this approach was used through an interleukin receptor antagonist molecule called anakinra, and this was a randomized controlled trial on about 100 patients, equal amount randomized to standard of care using corticosteroid, or the anakinra combined with zinc and pentoxifylline therapy. So it was a triple therapy, which was the intervention arm compared to corticosteroid. As you can see, the 1 month mortality was no different, but however, the 3 months and 6 months survival in the treatment arm was beneficial or a trend towards benefit. And based on these data, this drug is now moving on to phase 3 clinical trials to assess their long-term benefit in the treatment of severe alcoholic hepatitis. And this is a very, very exciting molecule and a very unique in my mind in terms of its way of action, which is called DUR928. And the way it acts is that it upregulates the regeneration effect and downregulates the inflammatory, the activity in alcoholic hepatitis. And about pilot study, there were about 18 patients studied, 12 of them with severe disease with a MERIT score over 20. And as you can see, the primary endpoint, which was a response rate as defined by the Lille score, was achieved in more than 80% or up to 90%. And a median Lille score in this study was about 0.1 to 0.2. It was significantly improved if you take about historically steroid-treated patients where the median Lille score was over 0.5. An important part of this study was that 100% survival was noted. So everybody in the study survived 28 days. This has never been seen previously in any severe alcoholic hepatitis clinical trial. On a similar note, the interleukin-22, which is one of the IL-10 family regenerative molecule with a strong hepatoprotective effect, and with the same kind of a phase 2 dose escalating study. Of 64, only 18 could be randomized, and that shows the difficulty in enrolling such kind of patients in alcohol-associated liver disease. However, of the 18 patients, 6 patients in each dose were randomized, 10 mics per kilo, 30 mics per kilo, or 45 mics per kilo. And at each dose, there were 3 patients taken which were moderate disease and 3 patients taken which were severe disease. And it showed clearly a benefit in terms of improvement in MELD score or a change in MELD score, especially when the analysis was done at day 42 or 6 weeks. There were also some benefit at day 28, but clear benefit at day 42 in terms of improvement in MELD score. We look at LIL score, which is a response to the treatment at week 1 after treatment with IL-22. Similar to DR928, you can see over 80% response rate, which is clearly better than 56% in a historic steroid-treated patients, and very low no treatment patients, which is about 6% in a retrospective cohort and 12% in a prospective cohort, so clear benefit. And this study was important because they also looked at the mechanism in terms of looking at extracellular vesicles concentration, which showed a significant decrease in the treatment arm compared to the non-treatment arm. And also the cytokines, the inflammatory cytokines. On the left part of the right panel, you can see a decrease in the inflammatory cytokines and an increase in the cytokines and chemokines of the regenerative, especially the fibroblast growth factor and platelet-derived growth factor. There was an increase with treatment. Now, let's move on to one of the more controversial molecule, which is growth factor or the granulocyte colony stimulating factor we all are aware of. And the upper panel is a randomized controlled trials. There's 7 trials meta-analysis on about 600 patients. 200 of them received G-CSF, 400 received placebo. And as you can see, the odds ratio is in favor of the molecule of G-CSF with about close to 70% survival benefit with the treatment at 90 days. However, if you substratify these patients or these trials with the 5 trials from Asia, from either ILBS or PG at Chandigarh, there is about 85% survival benefit. However, if you take only 2 trials from Europe, there was no benefit of G-CSF compared to placebo. So clearly there is some differences, and not only the results from the 2 different continents, probably reflecting 2 different patient populations from these 2 different continents in the field of alcoholic hepatitis. And I'm showing you the recently published the European, one of the European studies over here, showing you the negative study of G-CSF, where G-CSF was used in about 176 patients randomized to either G-CSF or placebo, and the G-CSF was used 5 mics per kilo for first 5 days, followed by the rest of the 3 weeks every 3rd day in the same dose. And the analysis was done at 90 days or at 1 year. Again, 176 patients equally randomized to the 2 different groups, either standard medical therapy plus G-CSF or standard medical therapy alone, and analysis at day 90 and day 360. And this shows you the change in the MELD score or the organ failure score. There was no difference in the 2 arms, as you can see, whether you talk about the organ failure score as determined by the Easel-Cliff criteria, and or the MELD score change with the treatment. And this table shows you the remission of acute and chronic liver failure in the 2 arms was not similar. The recurrence of ACLF was similar. the complications of liver disease, whether you talk of ascites, encephalopathy, hepatorenal syndrome, infections, or varicose bleed, there was no difference in the two groups. So clearly telling us that this was a negative study and we need more data before recommending in practice for or against this molecule in the treatment of ACLF or alcoholic hepatitis, which I think is a major driver of ACLF, not only in any liver disease, specifically in alcohol-associated liver disease. So I just put down this table of some of the other phase 3 trials. I think everybody is aware of this N-acetylcysteine, which is a pure antioxidant. And this was in combination with prednisone in the treatment arm and prednisone alone in the control arm, where the IV NAC was used for first 5 days. And then in combination with prednisone, there was improvement at 1 month, but then later on, there was no benefit in terms of the survival of the patients. But this drug was peculiar that the HRS-related mortality, even at 6 months, was more beneficial in terms of the treatment arm compared to the control arm. The metadoxin, which is a unique molecule that not only it is an antioxidant, but also has some abstinence effect or decreasing the craving of drinking. And this was studied in an open label and also in a combined with prednisone or pentoxifyrin. Not a very large sample study, but it was in severe alcoholic hepatitis with discriminant function more than 32. There was improved survival shown with metadoxin when it was combined with either of the two drugs which were available at that time, either prednisone or pentoxifyrin. I think the more exciting combination will be with augmentin with prednisone. And I think the data of this are awaited from the Franco-Belgian group, which did the initial early liver transplant study from Phil Matherin's group, and the outcome will be studied at the 2 months period. And these are some of the phase 2 studies, not only through the gut-liver axis, which probiotics or rifaximin, but some of the inflammatory molecules or anti-inflammatory molecules like canakinumab and obeticholic acid. And I think an exciting molecule, which is omega-5 fatty acid, which has been studied in ACLF, but also phase 2 study in alcoholic hepatitis. And one of the points I want to bring out to a busy table here, that learning from our initial experience in clinical trials in alcoholic hepatitis and recognizing that we cannot ignore moderate alcoholic hepatitis, these new trials, not only recruiting severe AH patients, but also those where the MELD score is below 20 in moderate alcoholic hepatitis. And one of the important developments in this field is also that liver injury keeps on going for up to at least 3 to 6 months from the alcohol effect. So the driver of primary outcomes should not be limited to 30 days, but also maybe 3 to 6 months from the time of recruitment of these patients into clinical trials. And this slide I put because it fits with this symposium put together by Anil, because we learned initially in the second session about newer drugs in the NASH world. And I think over the last 20 years or so, since NASH came into existence, more importantly in the field of liver disease, that we've recognized some of the similarities and some of the differences I will not go over. We all know that between these two diseases. But I think one of the things which we need to learn from the NASH world more is in the treatment of alcoholic hepatitis and alcohol-associated liver disease is the role of combination therapy. And I think one example clearly is the combination of steroid with an antibiotic, and the results are awaited. But I think this combination therapy is lagging behind in alcoholic hepatitis. And to me, it will make a good sense of combination therapy the way in the NASH world, the recognition has come of importance of combination therapy in the field. We are lagging behind in alcoholic hepatitis area, especially combining molecules which act through down-regulating inflammation, especially steroids or some of the other molecules, along with some of the hepatoprotective molecules, whether it is IL-22 or GCSF or obeticholic acid or even DUR 928, some of the molecules which have shown some exciting data. Now, changing not only gears, but also taking a step back, recognizing that control of the risk factor is the most important determinant in the long-term outcome of patients with alcohol-associated liver disease and alcoholic hepatitis. And Alex Louvet, in this nicely done study, in which they followed their survivors of alcoholic hepatitis patients over 5 years and showed that not only it is decreasing the alcohol intake, but also it is the total abstinence, which is important if you want to have the best outcome of these patients. Because even if you decrease your alcohol intake after recovery from alcoholic hepatitis to a moderate level, which is less than 30 grams per day, your risk of dying over 5 years is 2.3-fold. So abstinence should be the rule rather than cutting down in this advanced liver disease patients. And that brings us to the discussion on treating their alcohol use disorder, which is the second pathology in these patients, other than liver disease, which they already have. And there are more and more data now coming that concomitant treatment of their alcohol use disorder not only decreases the risk of new decompensation over follow-up in these patients, their risk of readmission is reduced. And this is associated with improved survival over time. And this has also been shown in some of the database studies where a discharge diagnosis of alcohol use disorder, which is a sine qua non of that addiction medicine saw the patient during the admission for alcohol use or alcohol-associated liver disease, and that correlated with the reduced risk of 30-day readmission due to a liver-related event. However, the concomitant management of alcohol use disorder in these advanced patients is an exception rather than the rule, not only in the US, but all over the world. For example, in this study, retrospective study of over 35,000 veterans from the US, the alcohol use disorder treatment was less than 15% of these patients of everybody who qualified for a diagnosis of alcohol use disorder. So you can see that this treatment of alcohol use disorder is so rarely used in the world, and especially the pharmacotherapy is less than 1% of this population. So clearly, we need more and more interventions to improve the treatment of alcohol use disorder in our patients who have alcohol-associated liver disease or alcoholic hepatitis. And some of the barriers which make it difficult to incorporate into our daily practice. Let me start with clinicians. What could be the barriers? And on the right-hand side are proposed strategies which could overcome these barriers. So I would just go over some of the barriers that I think if we talk about physicians, probably recognition of AUD screening, not only by the gastroenterologist, but also more importantly by internal medicine and primary care doctors, lack of awareness. And I think more important is time, lack of time in, when they're busy in their own practices, looking after other issues, the screening for alcohol use disorder kind of left behind. That makes it difficult to incorporate management of these patients for their alcohol use disorder. And one of the important things is training of hepatologists. I think we are all, if we talk about us in our group, we are not very well trained to manage management of alcohol use disorder, even if we identify the patients having this problem. Coming to patient level, I think there are a lot of barriers. Again, about awareness and education. Insight is a major issue. People don't think that they're drinking enough, that it could cause liver disease, and there are a lot of myths in terms of how much they can drink in terms of their liver harm or harm related to alcohol into causing liver disease. Some of the patients may not be willing to undergo treatment because of the stigma attached to this disease. And then obviously, when these patients are having an advanced disease, they may be sick enough that they cannot go through the treatment for their alcohol use disorder. They are more focused on their liver disease problems like ascites or liver failure and other things which are going on simultaneously in these patients. And I think the most important barrier in my mind is the system or logistic barriers of putting together strategies of integrated or at least concomitant management of alcohol use disorder, whether you talk about barriers at the level of insurance or manpower or resources, and to put together two specialties in managing a single patient, billing issues in terms of how you can bill seeing a patient under one roof by two different providers. And that puts most of the practices all over the world having kind of a siloed or separate practices of managing addiction and hepatology in these patients with advanced liver disease. So this is something we put together recently into how we can put together an integrated approach by two different providers and specialties in managing advanced liver disease patients from alcohol. I think the right part of this picture is more applicable to today's talk, which is alcoholic hepatitis. So those patients who are screened to have at least moderate to severe alcohol use disorder based on whichever component you choose or tool you choose, whether audit score or DSM-5 questionnaire. And once the patients have moderate to severe alcohol use disorder, they should be integrated with multidisciplinary team with addiction and personnel. And I think in my mind, there is always a two-way street rather than a one-way street, that from hepatology we go to addiction medicine. I think people who enroll who may not have an apparent liver disease, who come to an addiction medicine or to primary care doctors, and they should be screened for alcohol use. And if they have a harmful alcohol use or alcohol use disorder, they should not only be screened for liver disease, but also their associated fibrosis risk in these patients who have alcohol-associated liver disease, and those who have high risk of fibrosis, using either a serum marker or a radiological marker or both, should be integrated with hepatology. So I think this integration is not only one way, should be both ways, so that we can manage these patients, those who have advanced liver disease, but also those who have inapparent early liver disease, to improve their long-term outcomes. So this is the closing part of this talk, where there are some take-home messages that there is definitely, I think, we saw enough data that we have a clinical unmet need, that we need newer therapies for alcoholic hepatitis. And not only for the severe alcoholic hepatitis, but even for moderate alcoholic hepatitis. And some of the promising agents in this field. Clearly, GCSF needs more data before we can recommend in the routine practice. And complete alcohol abstinence should be advocated and determines the long-term outcome. And we need strategies to integrate implementation of integrated care model, or if not integrated, at least concomitant management of alcohol use disorder in these patients who have advanced liver disease, so that they can improve their long-term outcome. I will stop here, and I think we have already gone over for the whole symposium today, but I'll be happy to take questions. And thank you once again.
Can you stop sharing your screen, sir?
Yeah, just a minute. Okay.
Thank you, Dr. Singhal, for that wonderful overview. And I think this is a very hot topic in all parts of the world, and I'm sure it's going to invite a lot of comments and questions from the panelists. For starters, let me introduce the panelists that we have for this session. We have Dr. Lubna Kamani, who's an associate professor of GI at Aga Khan University Hospital. Dr. Neerav Goyal, who is a liver transplant surgeon at the Apollo Hospitals, New Delhi. Dr. Vivek Raj, who is the Principal Director and Head of the Department, Center for Gastroenterology, Hepatology and Endoscopy at Max Super Specialty Hospital, Saket. And Dr. Neeraj Saraf, who is the Director and Head of Clinical and Transplant Hepatology, Vedanta the Medicity. And Dr. Sanjeev Sehgal, who is the Principal Director and Head Hepatology and Liver Transplant Medicine, Max Hospital, Saket. So I think we can start inviting comments from the panelists, and as we carry this discussion forward, ladies first, Dr. Lubna, your comments please on this talk, and if you have any pressing questions regarding the conversation we had.
Can you unmute yourself? Yeah.
And thank you, Dr. Arora and the team for the excellent presentation and the conference. Very good presentation by Dr. Singhal. Definitely, there's no doubt that we need desperately new medications for alcoholic hepatitis, because now we have very limited choice of treatment. In Pakistan, alcoholic hepatitis, thank God, fortunately, is not a major problem because of various religious restrictions. But working in a tertiary care hospital, I work in 2 tertiary care hospitals. We see advanced cases of alcoholic liver disease, CLD. The main problem that we face is once we treat these patients, the patients stop taking alcohol, but somehow after few months or few weeks or few years, they again restarted taking these alcohol. And they tend to forget all what has happened in the course of ICU last few years. So these patients should be engaged lifelong with the hepatologist, with the psychologist, with the psychiatrist, with the behavior therapist, and there should be a multidisciplinary team because these patients need lifelong engagement with therapy, psychotherapy, because that is the major hurdle. Because once they start drinking, the relapse is more severe as compared to previous single episode. It would be interesting to see these medications hitting the market, and we desperately need these medications. But still, these medications are in phase 2 and phase 3 trials. Very nice presentation once again.
So, Dr. Singhal, the comment Dr. Lubna is trying to make is that many of these patients, they go back to their drinking ways, and you highlighted towards the latter part of your talk that actually we are dealing with 2 disorders, not one. Whereas we clinicians, hepatologists tend to be focused or we tend to be just liver centric. Any new exciting pharmacotherapies in the alcohol use disorders?
Yeah, I think I agree with everything Lubna said about the nature of this disorder of alcohol use. It's a relapsing disorder. Even if you talk to people who are experts in managing this disease, they also would say that the relapse rate is as high as 50 to 60%, even after going through a bad disease of decompensation and alcoholic hepatitis at 1 year after their enrollment, even after treatment. So the relapse rate is very high. Now, coming to, I didn't go over for the sake of time about the drugs in the management of alcohol use disorder. The acceptable treatments of the FDA-approved acamprosate, disulfiram, and naltrexone. Disulfiram is clearly contraindicated. Naltrexone is contraindicated in child B and C patients. Acamprosate can be used, but has acceptability issues because of the number of pills and the number of times you have to take it. So baclofen is something which is not FDA approved, but is shown to be safe in these patients. And gabapentin is another which is endorsed by actually APA or American Psychiatry Association, so can be used. Some of the newer therapies, topiramate is out there, wherein cyclin, which is anti-smoking drug, has been shown to be effective in clinical trials and can be used. And some of the newer molecules working through oxytocin mechanism are also in the pipeline in terms of managing alcohol use disorder. And I showed you the data on FMT in terms of reducing alcohol use disorder. simultaneously with improving the liver disease.
Right. Dr. Vivek Raj, can I have your comments on this session or any questions that you might have?
Thank you very much for a wonderful presentation, very comprehensive, Dr. Singhal. Actually, mine is a more of a layman request and comment from all my panelists. Every time I talk to my patients about stopping alcohol, even the ones who are drinking moderately or the ones who have had some degree of alcoholic hepatitis, they quote me the rule that we have been following: 21 units a week for men and 14 units a week for women is considered safe or moderate. My question to Dr. Singhal and to the audience is, and to the other panelists, is that in the Indian setting, my personal feeling is that it's still too high. And I think primarily because we have a high incidence of non-alcoholic fatty liver disease, diabetes, and now increasing obesity. Is there any data to suggest, or is there anything that we can recommend to the patients what would be considered so-called safe, although 0 is obviously the best number to quote, but is there anything that we can be guided by?
Yeah, that I think is an important question, and I don't think there is any data on safety of alcohol or modifying the safe alcohol use in obese patients. To my understanding, even if you look at the definition of safe alcohol use by NIH or NIAAA to talk of the US, this definition still stands as 14 and 21 drinks a week in females and males respectively. I completely agree with you that alcohol and BMI are interactive in terms of causing the liver disease. But when you talk about somebody who has had a liver disease, especially of the advanced kind, cutting down, as we've shown the data over long term, is still risky in terms of the survival benefit or survival outcome. So complete abstinence should be the rule rather than cutting it down. The only place where there could be a cutting down effect would be someone who has been transplanted for alcohol-associated liver disease, and you are managing their alcohol use disorder in the post-transplant setting. I think there is more and more acceptability in cutting it down to a more safer limits we just decided or defined. If you can go down to that number, and WHO has clearly defined on the outcomes if you're using, say, medications, for example, baclofen or gabapentin or whatever medication you choose, that you should go down by at least 2 risk reductions. So there are levels of alcohol use they have defined based on the amount of alcohol. So if you reduce it by 2 or more levels, I think there are a total of 5 levels. That's called, counted as a success in treating alcohol use disorder. In the liver setting, would be only applicable to post-transplant, but not to the pre-transplant. Yeah.
Thank you.
So I think the other panelists are all people who are engaged in active transplant programs. Let's start with Dr. Nirav. Dr. Nirav, your comments on taking up patients for early transplant when they have got severe ALCHEP and they are not responding to medical treatment. Is Dr. Nirav there?
Seems to be missing. I think.
All right, Dr. Neeraj, can I have you take that question, please?
Yeah, thank you. Excellent talk, Dr. Singhal. So, you've talked of many new drugs in the pipeline, FMT, interleukin-1, IL-22. And I think the obituary for GCSF has been written now with the multi-center European trial really showing no benefit. So we really have nothing to fall back on, except corticosteroids and liver transplant as of today. And so that, to what Dr. Dharmesh has asked. So yes, I think liver transplant for severe alcoholic hepatitis is definitely something which is here to stay until we have, better medical management. And I think we all have gained experience in the last few years of performing transplants in these patients with reasonable success. Of course, the ideal would be that you treat them with corticosteroids like the earlier papers, and if they are steroid failures, then you go for transplant. But that's not always possible. It would be that you treat them with corticosteroids like the earlier papers, and if they are steroid failures, then you go for transplant. But that's not always possible. It would be that you treat them with corticosteroids like the earlier papers, and if they are steroid failures, then you go for transplant. But
that's not always possible. It would be that you treat them with corticosteroids like.
Yeah, so sorry, Neeraj, for the technical glitch. Yeah, continue.
Yeah, so your comments, Dr. Singhal, on, I think we still have corticosteroids and transplant only. That's it.
Yeah, I mean, as we saw in the beginning of the, the presentation, that those are the only two, at least endorsed by guidelines, whether you talk about ACG, ASLD, or EASL. The two approved therapies for either steroid and steroid non-responders who continue to deteriorate liver transplant. But I think you made the point already, that although liver transplant is
the steroid and steroid non-responders.
Although liver transplant is unacceptable for non-responders, but if you talk of the whole pool of alcoholic hepatitis, that treatment is applicable to maybe just 2% of the population, because the criteria for selection or eligibility are so rigorous. You have to have an excellent psychosocial support, which all these patients cannot or don't afford to have. So I think if you take the 100 patients who fall into that category, only 2 or 3 would ultimately fall into the basket of, maybe with more and more awareness and exception pathways for transplant, maybe 5 to 10% is the max you can take these patients. So still 90% of patients who are non-responders to steroids are not eligible for liver transplant. It's a big number of patients where we need newer therapies for sure.
Dharmesh, can I ask a question?
Yeah, please.
Yeah, Dr. Ashwini, I fully what you are saying, that only 1 to 10% of those requiring failing. Dharmesh, can I ask a question? Please. Yeah,
Dr. Sidhu, you would have to unmute yourself, sir, because you've got 2 systems on. It is echoing.
Can I ask a question? Okay. Sorry for the technical glitch. My question is not Ashwini. Sir, all those, at least in India, who fail to respond to steroid, which they are likely to do so because of the limited efficacy of the steroids, are offered transplantation. I'd like to know from Neeraj and Sanjeev, how strictly, how frequently do they follow the New York criteria for selection, as mentioned by Dr. Ashwini, in terms of the first attack of alcoholic hepatitis, in terms of an excellent support? What I presume as a hepatologist is either steroids or transplantation. I don't think we follow any criteria after steroid fail.
May I interject?
Yeah.
You see, one important thing that came up in an NIA meeting last year was that they have issued some futility rules for treating severe alcoholic hepatitis. And precisely, they have said that if you have a MELD score of more than 35, then you have an 80% mortality in 90 days. Now, unfortunately, in our country, all the patients have a MELD score around this. So the Western medicine trials of steroids or be it any other trials, unfortunately, are virtually not meant for our population at all. So I think we have to generate our own data as which drugs are useful for us, which are unsafe for us. And it is clear that we are, as a population, unsafe for steroids. And the reason for that is probably given in the fact that all our patients are suffering from severe sarcopenia, which makes them very prone for infections. So therefore, steroids might be very good for the Western population, but unfortunately, their MDF scores and their MELD scores are way low than our MELD scores and MDF scores. Therefore, all this data completely is of no use to us, because we don't fit into the data. We are already excluded if you see these futility rules. So the question comes to the wider audience, then what do we do? And I guess the answer is that we have to start doing multicentric trials on certain things that might be helpful. For example, FMT, maybe a bovine colostrum, and nutrition, of course. You see, there has been ample data to show now that if the person is taking less than 21 kilocalories, the mortality rate is high. And if you take more than 66 grams of lipids and 77 grams of proteins, then the mortality rate improves. But over here also, there's another important issue. What the patient takes and what you give what you ask the dietitian to give to the patient are two different issues. The next day you realize that the patient has not taken even 1/4 of what you have asked him the patient take. So these issues are really important for us. Unfortunately, steroids and the rest of the things have been cannot be applied to our population.
So Dr. Singhal, as we all know that in patients who present with ACLF in the context of severe ALK-HEP and especially ACLF3, they are likely to be steroid non-responders for all practical purposes. So should we pass this message that probably this is a cohort which should not even be treated with steroids? Because even in the earlier Philip M. Mathurin's paper, the number of patients with invasive fungal infection, especially invasive aspergillus, was extraordinarily high. 5 out of 26 patients, if my memory serves me well. So in our country, that's going to be a real challenge in the post-operative period. So if we are indeed going to offer them transplant, should we have tried steroids at all? I would say that probably the people who have not been subjected to steroids might form the best cohort for considering for transplant.
Yeah. I mean, if you apply the standard eligibility criteria, and I agree, if somebody has cardiopulmonary failure and GI bleeding or active infection, those are clearly no's for even trying corticosteroid, but because those are not eligible patients for corticosteroid therapy. Now, if you focus mainly patients who don't have these complications, there will be large group, and as Sandeep pointed out on. Based on the MELD score in terms of utility of corticosteroid, we looked at it because we have a lower limit of when to use steroid in severe alcoholic hepatitis patients, over 20, but I don't think there is an upper limit of where we can show the futility. So about 3,000 patients, the paper came recently last month in Journal of Hepatology, about 3,000 patients retrospectively were studied. And we came with a therapeutic window of 21 to 30. So anybody who has a MELD score over 21 has a benefit, but you start losing the benefit at a MELD score of 30. So maybe MELD score over 30. Sorry about this. Somebody's at the gate. So MELD score over 30. Maybe you can forego steroid use and focus on maybe if the patient is applicable for liver transplant. If you want to prevent infective complications and other issues or time, for example, don't want to. The point I want to make here is whether you talk about transplant from diseased donor or live donor, the diseased donor coming from US mostly and live donor mostly in Delhi or India in most centers. The criteria for patient selection, in my mind, should be similar. And as Anil pointed out, should be an excellent psychosocial support in these patients so that you can tailor down the best patient population to have this outcome. Now, in terms of utility of medical care itself, I think there is a group of patients who, whether are steroid eligible or steroid non-responder, so ineligible patients or steroid non-responder patients, if they are not a transplant candidate also, but if they are having multiple organ failure, especially in ICU, you may start talking to them early on, maybe in a week or 10 days from their presentation. And if they're not improving, start talking to them with goals of care or something, because we have all seen and experienced these patients may linger on for weeks to months without any survival benefit at 3 months. They may have over 95% mortality. So patients who are ineligible or non-responsive to steroids, are not transplant candidates, multiple organ failure, maybe start early on goals of care and the end of life care issues, because the chances of them surviving are very, very.
Dr. Anil was alluding to the first episode of severe ALK-HEP versus someone who's had it in the past, whether diagnosed or not diagnosed. What are your thoughts on that?
Yeah, this is an important thing. If someone has had a decompensation from alcohol or alcoholic hepatitis in the last few weeks or months or years, but if somebody has had 3 years or 6 years before an episode of alcoholic hepatitis and has stayed okay and now comes with another episode. I think those two are different patients. So in my mind, I would take that not as an absolute, but just judgment call based on, and this is what we do in our transplant discussions, based on how far that second episode or the first episode was.
Dr. Sehgal, what are your thoughts on patients who come in with organ failure right at the time of admission and high melders, whether to use steroids in them at all or just manage them medically with nutrition and whatever you might want to use, and then if they are not getting better, to start talking to them and the family about liver transplant? So are you a steroid advocate or a steroid beta?
Thank you, Dharmesh, for this excellent question. But let me first congratulate Dr. Ashwini for a very fantastic talk. It shows how much elaborately you have been pursuing your interest in alcohol liver diseases, and your publications have been really wonderful. So I will congratulate you for that. Dharmesh, I think both of us agree to the same thing. We have been discussing this over the last several years, and I honestly have not seen any major change happening in the clinical practice. There may be huge publications, but let me honestly tell you that practice has not changed over the last maybe a decade, even for that matter. We still have the same feeling. If somebody comes to me with multi-organ failure, has evidence of sepsis, is not doing well, I would be very hesitant giving steroids. In fact, my patients who actually end up having steroids, that is now coming down more and more to a very small category. Also because that we are practicing in a very highly specialized centers, and patients who come to us, like me and you, they are already treated outside, and only when they are very sick they come to me. So to answer your question, no, if somebody has multi-organ failure, has got sepsis, ascites, GI bleed, renal dysfunction, I will not really jump onto steroids. I have seen them actually worsening more often, which is one worry. But I agree that, as Dr. Ashwin is telling, a very minuscule percent of patients overall end up having transplantation because of affordability, donor money, and so on. So we cannot just simply jump onto the transplant story. That should not be the thing right now. I think we need to take a change in gear. We have to understand that no, transplant is not the answer because it has a lot of limitations and it is not something which is accessible to all. So combination of therapies, the newer molecules, I think something like that has to come up in picture. And till that time, we have to be supportive in our treatment. And of course, in our practice, when I see a patient like that in ICU, we simultaneously start, like priming the family that there would be need of transplantation after thorough assessment and, family patient counseling, and which is something which we follow. And of course, I will tell you that sicker patients we are doing these days, they are actually, with the large experience which the team is developing, the surgical experience which has also increased, actually we are getting good results in even those who are very sick. So there are two aspects to it, but my personal feeling is that we need to actually develop more on the medical grounds, and that is a need of the hour, Dharmesh. Thank you.
Singal, what are your thoughts on plasma exchange? Again, this is a therapy which is low throughput in our part of the world and very commonly used. So what are your thoughts?
You're asking me?
Yep.
Yeah, I personally have no experience, or even we don't use plasmapheresis in our patients. MARS has been shown in any ACLF patient to have some bridging effect if the patient is a candidate for liver transplant. So you can improve their liver function, maybe encephalopathy or renal function, and then bridge them, even portal hypertension, and bridge them to transplant. But plasmapheresis, I personally do not have much experience on using in patients with severe alcohol hepatitis. So I don't know what the panel thinks about, which I think is all worthy panel on liver disease and hepatology. So I'd like to listen what everybody thinks.
I think we are already getting some comments from Dr. Saraswat that we've been given the freedom for this being the last session and overshooting. Lastly, what about FMT? So what would be your ideal patient for FMT?
It's too early to say. It's still in clinical trials. So I don't think FFT is approved. Even for clinical trials, FFT is used as an FDA approved application for an indication. So I don't think it is approved for therapy as a therapy in the treatment of alcoholic hepatitis. So in clinical trials, it is still, people are very, very cautious in selecting their population. For example, VCU, the paper I showed you, picked up very moderate patients, the MELD score below 20, for proof of principle showing safety and the double effect on gut-liver axis and gut-brain axis. And I think now, once they have shown safety in this population, they may move to include more sicker population with a MELD score over 20 and severe alcoholic hepatitis. But in general, I think if you talk in sicker patients with MELD over 20, FMT has not been studied. No, I don't think so.
Do you have any reservations about the FDA warnings regarding some of the bugs going systemic, and in more recent times even fungi?
Right. That is the concern, that even if the paper I showed you about the San Diego group, I think they had a problem, and that's why the paper was translated taking samples from alcoholic hepatitis patients rather than using that approach in patients itself, because around the same time there was a patient with an FMT, not for liver disease, but for other disease, where it was shown an E. coli septicemia as a complication, and the patient died as a complication of FMT. I forgot which disease the FMT was used for in that particular study, but that was one of the complications. And that's the fear, more so in patients who have severe alcoholic hepatitis. You're right.
So I think we can conclude this session, even though this discussion might go on and on, because this is such a important topic for practicing clinicians. Dr. Sidhu, can we have your final comments before we wind up the session and hand it back to Dr.
No,
Ashish?
I agree with Dr. Singhal on all of what he said, but I like to reiterate that our population needs probably a different approach altogether. I think we have to concentrate more on improving their nutrition, and we need to focus on certain targets in nutrition, especially in sarcopenia, like hand grip strength, improve that so that their overall muscle strength performance improves, so that these patients are more strong enough they have a better immunity to fight infections, because the biggest killer in our patients are probably sepsis. So I understand that almost everybody would agree with that the biggest killer is sepsis, followed by GAV or something of that sort. So till we have a better drugs to suit our population whose MELD score is more than 30 or 35, we will have to restrain ourselves away from steroids, concentrate only on the basic medical approaches, and wait for better molecules that are already in the pipeline.
Sure. I think we can hand it back to Dr. Ashish, and thank you everyone and Dr. Singhal for such an engaging discussion, and to all the panelists for very active participation.
And I would like to thank everybody again for this organizing, especially Anil, and it was a pleasure to be talking to everyone on the panel and everyone listening to everybody's presentation. I logged in before the symposium started, and I heard all the talks, and they were all great. And thank you, Anil, for doing it. And I hope to see you all in person soon. Yeah.
Thank you, sir.
Thank you, Dr. Ashwani, for those encouraging comments. Thank you, Dr. Dharmesh and Dr. Sidhu, for moderating this session. So this brings us to the end of present day symposium. And to summarize all the 5 talks, I would invite Dr. Praveen Sharma, who is my colleague and co-organizing secretary, to give a summary of all the talks within 5 to 10 minutes, and then we'll wind up. Dr. Praveen.
Right, it will be a difficult task to complete everything in 5 minutes, the 5 talks. But let me summarize. The first one was by Professor Anjali, who gave advances in the management of refractory ascites and its management. He talked about definition, he talked about problems which we face, he talks about neuropathogenesis, the role of anti-inflammatory drugs. Probably to summarize in one single sentence, I think the role of albumin, judicious role of beta blockers, role of tips in certain patients, And probably if the patient is fit for liver transplant, that is the best method to treat a patient with refractory ascites. The second talk was by Professor Mazan, who talked about the recent advances in NASH. Though the FDA approved drug is only vitamin E plus the weight reduction, he talked about number of other drugs which are in pipeline, mainly the obeticholic acid, that is the FXR agonist, which is probably in the next pipeline drug. He talked about FGF 19 and 21 agonists, which probably will have a good role in the management of NASH. He talked about thyroid receptor agonist, especially the beta agonist, which is specific to the liver. And he talked about the newer drugs for the fatty acid synthesis inhibitors. Probably a combination of drug is most probably the newer upcoming things in the management of NASH. GLP-1 agonist and combination, I think probably has got some role which will come in the future. But till now, to summarize in single sentence, weight reduction and vitamin E is probably only the therapies which are available to us. Semaglutide in India is approved but not worldwide. The third talk was by Professor Yao, who talked about advances in the SCC. I think in a single sentence we want to summarize in the talk is the use of immune check inhibitors. Now the first line of therapy along with sorafenib and lenatinib is a combination of atezolizumab and bevacizumab in those patients which are suitable. It means there is no recent evidence of any bleed and there is no cardiac complications because of VEGF receptors antagonist. So probably atezolizumab and bevacizumab is now in India and in abroad will be the first line of therapy for the management of SCC. He talked about newer drugs, maybe a combination of tyrosine kinase inhibitor along with immune check inhibitors, but the results are still in pipeline. So probably the treatment of choice at the first line is sorafenib, lenatinib, and the combination of atezolizumab and bevacizumab. Professor Shiv Kumar Sareen talked about the hepatitis B. I think there is more of controversy whether we should treat all the patients of hepatitis B irrespective of whether their DNA and HbS quantification. His focus was on the risk factor for SCC, and that is the genotype C, raised ALT, raised DNA, more fibroscan, maybe more than 13. Patients who are obese, they are the risk factors. The protectors are the aspirin, statins, and the metformin. He advised against the use of insulin, which probably is not like feasible in every patient, but we should keep in mind that the insulin is a thing which can provoke SCC in patients with cirrhosis. We talked about page B and the M-REACH predictors of risk factors for the SCC. Till now, I think we continue to use tenofovir and entecavir as the first line of therapy, and probably the role of NAP, which is quite promising, but we need more data for the future trials. And but I still feel whether treating all patients of hepatitis B and whether to stop antiviral in patients who have anti-HBE and HbS quantification is less than 100 is a good, I think, upcoming thing. The last was by Professor Ashwini Singhal. I think if you want to summarize, it's a brilliant talk. He talked about the newer roles of interleukin-1 receptor antagonist, IL-2 agonist. So most of the trials are against GCSF, which he has shown the recent trial of J-hepatology. So I think this chapter is probably closed. But combination of therapy, probably the steroids with probiotics, with IL-1 inhibitors or anti-LPS probably will be the future for the treatment of alcoholic hepatitis. Along with Dr. Sidhu said, sarcopenia has to be taken care of and we should give more nutrition to these type of patients. So I think with this, we close this today's academic feast.
Thank you, Dr. Praveen. Before I hand over back to Dr. Anil Arora, I would like to propose a vote of thanks. I would like to thank all the speakers, moderators, and panelists who have logged in from so many different countries, USA with different time zones, for participating with their excellent talks and discussion. We learned a lot. And apart from that, there have been more than 1,400 registrations to this meeting. And it has been a hugely popular symposium today, and I hope that it will be similar tomorrow and then next weekend. I would also like to thank the academic partners, the pharmaceutical companies who have supported us, like Microlabs, Dr. Reddy's, NATCO, Abbott, many divisions of Abbott, Elnick Life Sciences, Medley, Medtronic, Zydus, Kedla, Bountiful, Boston Scientific, Ferring, Forts, and Samarth. And I would also like to thank our event managers, Maisha, for their excellent support and the logistics. And I would like all of you to join back tomorrow again, same time, 6 p.m. For an exciting talk on symposium on GI diseases. Now I hand over back to Dr. Arora for his final comments. Dr. Arora, you are muted.
Thank you, Ashish. I'll again take time to thank all the expert panelists, speakers, moderators, and chairpersons for the various sessions. I'm sure all of you as seasoned hepatologists have contributed widely to the relevant discussion on the common day-to-day hepatology topics. It was a pleasure and honor to have you with us. Tribute to your excellent presentations and your credentials. We had an excellent attendance today on weekend. Even though it was convenient for us sitting in India, being on the weekend, I can understand the problems Ashmi and others would have faced during their working hours in the non-weekend daytime. Thank you so much, all of you, for joining. And we look forward to have you all again at 6 p.m. tomorrow, being a Sunday evening, for an excellent presentation on the recent advances in the field of luminal gastroenterology. But I'm sure all of us do realize that we are not, especially in India, Pakistan, and Bangladesh, we are not pure hepatologists ever. So most of us tend to mix up other specialities also. So we look forward to see you. Good night and goodbye.
Thank you.
Tech team, we can log off. Thank you.